up. Yeah.
हाँ सर, वो सर्वर से आता है ना। आप लोग कितने बजे तक लेक्चर आते हो? हाँ, काम करता है।
नॉर्मल है, छोटा सा कुछ सेकंड 2-3 सेकंड का है, वो एक स्लाइड में ही चलेगा साथ में। दोनों पे बन जाएगा।
ये पेपर होगा।
हाँ ये लॉन्ग ओरल में है कुछ। हाँ जीवन नहीं है। हाँ मतलब पहले वीडियोस वाले होंगे उसके बाद होगा। यूरिन जो है ना ये फर्स्ट है। हाँ, नहीं वो फर्स्ट है मतलब।
अच्छा वो तो कर दिया।
हाँ ठीक
अब
है।
आप बताओ।
लॉन्ग ओरल में मैं लॉन्ग ओरल में
लॉन्ग
हाँ, हाँ जी हाँ। एक मिनट आ रहे हैं।
अच्छा
बोल दीजिए। क्या कह रहे भैया?
कौन सा
बोलना है।
पता नहीं है, खुलवा दे रहे भैया, एक मिनट।
नहीं ये वॉइस ओवर नहीं है। हाँ, ये तो छोटा यहाँ बोल रहे हैं। ये सेकंड वाले में। नहीं सुनो तुम अपने वाले में फिर बोलोगी क्या? नहीं तुम तो बोलोगी हमारे वाले में बोलो।
अच्छा खुल गया। हाँ अभी अभी खुला, वो तब से डाउनलोडिंग ही दिखा रहा था वो। मुझे लगा ही वो उधर से टाइम लग रहा होगा। अच्छा ओके। तो नहीं ये मेरा ये हाँ अच्छा ओके। तो ये अभी डाउनलोड हो गया कि नहीं हुआ है? ये वीडियो नीचे है, मेरा ये वीडियो है। ठीक। ये तो मैंने डिलीट कर दिया था, कैसे रह गया? चलो एडिटिंग करना पड़ेगा। ये इतने अच्छा उसको कुछ मत करो ना। ये वाला मैंने ना मिनिमाइज भी नहीं हो रहा है।
संदीप ये देखिए डेट ली है।
एक मिनट, वीडियो सेशन 1 प्रतिभा का है। देन
अरे मैडम, मैम ये आपके पास 14 का नहीं है? हैं? इसे 14 का नहीं है? पता ही लगा है। इसी इसी मेल खोल लीजिए ना। नहीं, खोल ले।
डाउनलोड कहाँ होगा? डाउनलोड हो गया।
ओके,
हाँ, स्क्रीन पे।
इसको बंद कर। नहीं, आप बैठिए, ये पेज पे
ये
नहीं, कट कट।
हाँ, तो हटा के मैं नीचे रख देता हूँ। अरे जो अभी कॉपी वहाँ उठा गया। हाँ, हम किया था वो, लेकिन हो नहीं रहा, गया। इसमें भी चेंज करना आगे वाले पेज में 3, इसमें भी 14 नहीं होगा, है तो पता नहीं।
पीछे डाल दीजिए।
वहाँ लूट करो।
बड़ा है।
पता नहीं खुल रहा है कि नहीं खुल रहा है। वही ऑर्गेनाइज वो वाली पीपीटी चेक
अरे
करना
छोड़ो छोड़ो छोड़ो, just say the name.
नहीं उठा रही चलिए कुछ काम करेंगे ना ठीक मैं करता हूँ बात
So, good morning. So, after a great party last night, it's good to see everybody back in the hall. So, welcome everybody for day 2. And we'll start off with the video session 1. Hand over to Dr. Pratibha, fellow in pediatric surgery.
Thank you, sir. Let's move on with the scientific session. Our first session will be a video session, and I would like to request the chairpersons to kindly grace the dais. Dr. Rasik Shah, sir, Senior Consultant Pediatric Surgeon, SRCC Hospital, Mumbai. Dr. Vaibhav Pandey, sir, Associate Professor, IMS BHU, Varanasi. Dr. Munir Malik, sir, Associate Professor, PGIMER, Chandigarh. Thank you, sirs. Challenges. Sir, actually, we are starting with challenges in choledochal cyst surgery, sir. The third presentation as the first, sir. Yes, sir. I would like to
choledochal cyst surgery, Dr. Avinash Jadhav, AIIMS Jodhpur.
Yes, sir. I request Dr. Avinash Jadhav, sir, to kindly present the paper.
ये है ना जैसे नेक्स्ट हाँ
Good morning to all the respected seniors and colleagues, greetings from AIIMS Jodhpur. So today I'll be presenting a paper on challenges in minimally invasive surgery for choledochal cyst. There is nothing to declare. As we all know, is an anomaly of bile ducts, which is characterized by disproportionate dilatation of the ductal system. In recent days, minimal invasive surgery has been gaining popularity for its management. The usual advantages are there, which are decreased hospital stay, decreased morbidity, reduced overall cost, and early recovery. However, sometimes we may face challenges with difficult anatomy, which is usually missed on investigations most of the time, because these are very complex anomalies, and even reporting those anomalies require expertise on the radiologist side. So this was a retrospective study. We reviewed surgical videos, and we have presenting a cases where we faced challenges, and along with the postoperative outcome of those cases. So in last 2 years, we had 15 cases which were either operated by minimal invasive surgery or open. 6 cases of these were included into the study, which had challenging anatomy or intra-op challenges. Rest, which were easier to do, were excluded. So this is the case 1. Was a 2-year-old female child who had presented with pain, jaundice, and fever for 7 months, 1 month, and 3 days respectively, and a large lump encompassing almost all of the left side of the abdomen and umbilical region. The hepatomegaly was 8 centimeters below the costal margin. On MRCP, there was gross dilatation of the entire biliary tree, and there was a paraduodenal cystic lesion which was reported as duodenal duplication. This is the MRCP which shows gross dilatation of the, and this is the surgery. We had now dissecting the overlying peritoneum over the, and going to and approaching the cyst. There was a large bilobed choledochal cyst which was exposed. We had a report which suggested a duodenal duplication along with the choledochal cyst. So we were going on very slowly and gently to delineate the anatomy. The intrapancreatic part, the lower part was quite dilated, and it was difficult to find the tapering end of the cyst. So we had to do quite a dissection into the pancreas, intrapancreas. The cyst was so big to handle that we had to take a hitch stitch so that it could facilitate our dissection. There were previous episodes of cholangitis, and that's why there were adhesions between the liver surface and the surrounding structures with the cyst, which we dissected with the cautery. There was huge dilatation almost up to the confluence of the hepatic ducts. So very small amount or very small length of common hepatic duct which we could find for anastomosis. It was reaching almost up to the confluence. So the dissection proceeded, and we had to dissect it up to the lower part. We had to use multiple energy devices depending on the scenario there and drop either cautery or a harmonic. And we had to go deep into the pancreatic tissue to excise the tapering part of the duodenum. On further dissection, we found out the bilobed structure, which was reported as paraduodenal cyst, was actually the part of a cyst which was adhered to the liver surface near the gallbladder. And it was reported by radiologists as a duodenal cyst, duplication cyst. So we had to remove it. We opened the cyst, and we found there was bile in the sludge in the cyst, that part of the cyst. We initially cauterized, expecting that we may or may not be able to remove it completely, but we were able to remove it completely. Then we proceeded with the hepatico-duodenal anastomosis. Owing to a very short stump of common duct, it was a bit challenging, but still we could achieve it with always the first stitch is a bit challenging stitch in the corners. Specifically, we have to take a reverse stitch when you are laparoscopy, a backhand stitch. So anastomosis was completed, posterior layer first, and the anterior layer was closed as the second layer. This is the completed anastomosis. And after that, the specimen was excised with the gallbladder and delivered out. So difficulties we faced was a large tense cyst, which had a difficult dissection with the previous episodes of cholangitis made it more difficult. The cyst was extending up to the confluence, leaving behind a very short stump for anastomosis, and the lower part was extending deep into the pancreas. So that was the first case. Second case was a 5-year-old female who again had repeated episodes of pain in abdomen, upper abdomen for 1 to 2 years. And the ultrasound was suggestive of a type 1 cyst of a size of 28 by 55 mm. In this patient, what the challenge we faced was a cystic duct was opening into a quite high, almost again into the common hepatic or junction of both the ducts, and both hepatic ducts were very small in caliber. So we had to convert this to open to achieve a proper anastomosis, as it was very difficult to do it laparoscopically. Second case was again had pain, fever, and jaundice with vomiting. And in this patient, what we found was the common bile, common bile duct was not that much dilated, was less than a centimeter, with a stone in the distal part. In this case, there was diagnostic dilemma. First of all, whether it's a stone leading to dilatation or it's a CBD or it's a choledochal cyst. ERCP was not possible as a smaller scope and expertise was not available. And in this case, we had to do a complete excision of the cyst, and because the cyst, it's important to excise the cyst completely. The fourth case was a 10-year-old female who had a pain in abdomen, and it was suggestive of a type 4 CDC. Ultrasound was of type 4 CDC. This is the MRI. The challenges we faced was cyst was seen opening into the pancreatic duct, and which was making the dissection of distal end very difficult, with a very small length of a tapering segment. Intraoperatively, there was a faulty incision placed on jejunum for anastomosis. We had attempted a hepatico-jejunal jejunostomy here, so we had to convert it to open and do it in that fashion. Fifth case was a type 1 CDC, which was done laparoscopically. It had a very smooth intraoperative course, but on post-op day 1, patient had frank bleed in the drain. So we had to explore the patient, and there was bleed from the artery to the bile duct, which was managed. And last case was the patient who had a anterior portal vein anterior to the cyst, and this was on finding the anatomy like that, we decided to convert it to open immediately without doing the dissection for the safety of the patient. So we conclude that CDC can present with various anatomical variations, which may or may not be described in the literature. Operations are challenging, although it may still be possible to do it minimally invasive. Every case has to be individually discussed with the radiologist preoperatively, and this might lessen the challenges that we face on the table. And we may be prepared before going into the patient. Thank you.
Nice presentation, Avinash.
Thank you, sir.
I have one query or question. The fifth case where there was a bleed from artery to bile duct.
Yes.
So what exactly had happened?
So maybe the bite must have been gone through the artery, which was not detected at the time at the time of surgery. We had a similar this I have not added, but one another case was there where the hepatic artery was also injured. Sometimes it can happen when there is a pre-existing cholangitis and the planes are not smooth. By taking a bite, a small part of the wall of the tissue, artery can come into the bite.
There was no bile leakage.
No bile leakage, sir. No bile leakage.
Any
In difficult cases, you prefer doing choledocoscopy intraoperative? Do you do for the
no, we have not done as of now.
like intrapancreatic portion was huge, so like,
Yeah, that
doubts
must have been
regarding
thought
the
about, but
confidence and all.
we just went ahead with the dissection, which was going on smoothly. So on laparoscopy, no, sir, we have not. Not laparoscopically, we have not done any single case where the Lilly's person.
So in difficulty, you can use even in laparoscopy.
Okay.
It becomes quite easy where you are not worried about this.
Okay, sir. Okay.
Any questions or comments from the house?
Thank you.
Also, a couple of cases where the duct was opening higher. So, could you identify three of them?
No, we were not. We could not. Not in all cases. Not in all cases.
I think if the facilities are available, it must be.
So yeah, but we are again stuck in the old dilemma of an anesthesia, separate anesthesia, and all those things. But yeah, I agree, sir. Nowadays it's very safe, and we should have a protocol.
Especially when doing minimal access. MRCP, and now MRCP standard of care.
Yeah. No. Yes.
comment on the terminology issue?
Yes.
The polyposis does not open it.
So maybe but speaking, I must have goofed up. Sir. Thanks. Thanks.
Thank you. Thank you.
Thank you.
Thank you very much, sir. Now I would like to call upon Dr. Ankur Mandalia, sir, who will be delivering a talk on video presentation on laparoscopic hepaticojejunostomy for choledochal cyst with variant biliary ductal anatomy, technical considerations and early results. Over to you, sir.
Good morning, chairpersons. So I'll be presenting our experience of laparoscopic hepaticojejunostomy for choledochal cysts, and with special emphasis on ductal anatomy variations and how we tackle them laparoscopically. So biliary ductal anomalies at the hepatic hilum, they pose a technical challenge, both in open and MIS surgery for choledochal cysts. Anatomical variability is the rule rather than an exception in liver and biliary surgery, and failure to recognize and appropriately manage ductal anomaly can pose a serious intra-op and post-op complication. So this is there are various classifications for the ductal anatomy branching. This is one of the classifications where the type 1 is the most common. It's a 64%, and it's a typical right posterior sectoral duct joins the right anterior sectoral duct, and it forms RHD which joins the LHD. This is the type 1. Then type 2 is trifurcation, where RPSD, RASD and LHD join together. That is around 5%. Type 3 is around 17%. In this type 3C, where the right posterior sectoral duct joins the cystic duct, or directly the RPSD joins the CHD, or sometimes it crosses over and joins the LHD. These are the dangerous anomalies where if you don't recognize them intra-op and you ligate them or just miss them, they can lead to cirrhosis of that segment of the liver, or it can lead to a biliary leak post-op. So we'll see what we found in few cases and what we did. So in the last 2.5 years, 28 children with type 1 choledochal cyst underwent laparoscopic excision of choledochal cyst with hepaticojejunostomy. So aberrant biliary ductal anatomy was found in 9, it was out of 28, so makes it 32%. The pancreatobiliary anatomy we routinely image by a preoperative MRCP in all cases, whether we do it open, lap or robotic. So that is standard in our institute. So out of 28 children, the correct pre-op delineation of the ductal variation could be done in 7 out of 9 cases. So 77% cases had correct identification of the ductal variation on MRCP. The 9 patients who had the variant ductal anatomy, out of that 4 had type 3B. We will see what it means. 3 had type 2 where the trifurcation anatomy, and 2 had a cystic duct variation, sometimes which is also known as the type 6 choledochal cyst. So we'll first see the case of type 3B anatomy, where the right posterior sectoral duct joins the level of the CHD just above the cystic duct. So we had 4 cases of this variety. So this is the first case. It is a 14-year-old boy. He had recurrent cholangitis. We did this MRCP. In this case, they didn't report a variant ductal anatomy. But if we look carefully, there is a faint duct maybe joining here, or we are imagining it, I don't know. So this is the patient position, which we do it for all laparoscopic edges. Patient is in this French position. Surgeon stands between the legs of the patient. The screen is at the head end of the patient. It's a short video. So we enter, we see the choledochal cyst. We make the posterior plane with the portal vein. So we always open the cyst below the level of the cystic duct. So if you want to identify any ductal anatomy, always open the cyst below the level where the cystic duct joins the CHD. So on opening it, we see an aberrant right posterior sectoral duct. You can see this duct here, which was opening in the CHD. Here we have maintained a common wall between them. If you cannot maintain this common wall, there are two options. Either you can do a ductoplasty and then do a single ostia anastomosis, or you do a double ostia anastomosis, which will become more challenging laparoscopically. So here we could maintain this common wall, and then we went ahead. The lower end is ligated and transfixed. Then we identify the DJ, we mark stitches, we do an extracorporeal JJ through the umbilical port, and then the rule limb goes inside. And then it's interrupted sutures. We usually use 4 or 5 PDS. I usually like to keep all the knots outside by a reverse hand suture, and it's a standard interrupted fashion. We do the HJ. So this is a single ostia HJ with ductal anomaly. Sorry, now we need to go to the next slide. Yeah. So we see another case. This was a 16-year-old girl. So MRCP here, they did report right posterior sectoral duct joining the CHD. This is the RPSD, which is joining the CHD. It's a very dilated choledochal cyst with even intrahepatic dilatations. You can call it type 4. So this is on entry. We again see there was an anteriorly crossing cystic artery in this case. Lower end we dissect till it's tapered. We clip it. Here again, I'll stop it. You can see this aberrant RPSD is joining this CHD where the cystic duct is joining the CHD. So we have identified it before opening the cyst. Then we have opened the cyst already. Then we go inside, again below the level of the insertion of cystic duct at the CHD, we see this opening. You can see this opening clearly of the RPSD, which is joining the CHD. Again, we try to maintain a common ostia. You can clearly see the RPSD and the right anterior sectoral duct and the left hepatic duct. The suturing is again in the standard fashion, and we can finish with the single ostia HJ. So next is that type 2 variation. Type 2 variation is where you have a trifurcation anatomy. So this anatomy does not have any surgical implications. All your three, the left hepatic duct and the RPSD, RASD are all joining at the hilum. It forms a trifurcation. It does not have a surgical implication. So as the first case, we again open it, and we clearly see here the right duct, which has 3 branches there, and the left hepatic duct. So this does not have a surgical implication. You can just go ahead and do your HJ. Another case, rest of the steps remain same. You can again clearly see the trifurcation, and the HJ is done in the standard fashion. Next is the cystic duct variation. 2 cases we had cystic duct variation. So a dilated cystic duct in recent classification, some people have called it type 6 choledochal cyst. This is a 3-year-old girl. You can see the quite a dilated cystic duct, which is there in all cases due to back pressure. But I'll show you what we found. So we go in and we see here that this cystic duct is actually more, this is cystic duct, and the junction with the choledochal cyst is actually more dilated than the cyst itself. Again, the same window with the portal vein, and there's a lower end tapering into the intrapancreatic portion, clip and divide it. Yeah, so here we again see hugely dilated bulbous cystic duct. I'm not sure if you can call it a variation, but it's a little abnormal. You don't see such a large cystic duct every day. Then you divide the CHD CBD junction, and you do the HJ in the standard fashion. So this is just data. I'll go over it quickly. We presented it at PACE, and our fellow got a first prize for this paper. So we had 9 cases. The mean age and weight at surgery was similar. We compared group with the aberrant biliary anatomy with the classical biliary anatomy. There was only difference we found was in the median operating time. The aberrant ductal anatomy, we obviously had to spend more time in delineating the anatomy and to carefully do the anastomosis single ostia, and rest of the parameters were pretty similar. We had 1 bile leak in each group, and which was managed conservatively. We had 3 conversions out of 28, and these are some of the children and the scars post-op. The parents are pretty happy with the cosmetic, and usually we discharge children around day 4, day 5, and so we can conclude that laparoscopic surgery for choledochal cyst with biliary ductal anomaly is technically feasible and safe. MRCP should be done in all cases to accurately identify aberrant ductal anatomy preoperatively, and precise dissection and delineation of biliary anatomy with appropriate management of the aberrant ducts must be ensured in every case to avoid serious intra and post-op complications. Thank you very much for a patient hearing.
Very good presentation, Dr. Santosh. Very nicely managed cases also.
Thank you.
I just want to know, it's not, is it better now?
Just lift the mic.
Okay, okay.
Yeah.
So I just want to ask you, how do you decide ductal plate dissection first versus your opening the cyst first and then seeing the luminal anatomy and then proceed further? Is it based on MRCP you see preoperatively, or is your standard practice you advocate?
No, the standard steps are same. Whether you do it open, lap, robotic, it's fine. It's the same. You dissect from the portal vein first, posterior dissection, then the medial dissection from the right hepatic artery, and then you go in the intrapancreatic part. Only difference is when the MRCP, like in 7 out of 9 cases, it showed that there is a ductal anomaly. So there we are more careful. Anyway, in all cases we open, as I said, the once you dissect the lower end and you clip the lower end, and the cyst is dissected from the lower part, you should always open the cyst below the junction of the cystic duct with the CHD. So that is always the safe area. You will not miss a ductal anomaly if you open it in that area. So the steps are same for all. There's no variation in the steps.
So there lies the importance of doing preoperative MRI and seeing the anatomy before and anticipating the.
Yeah. So if you know it, you will be little slow and even more careful so that the duct doesn't get missed. So that's what I think.
Wonderful presentation.
Thank you, sir.
And good series of cases. Couple of points I would like to ask. One is that you said you take a 4-0 material for suture.
4 or 5, 5 usually 5.
So that is the point I would like to
we take 5.
That in case there is no either, when I saw the suture, it looked like a 4. So that's why I'm commenting.
Yeah.
That if there is a ductal anomaly, the ducts are usually small. And smaller the suture and finer the suturing is more beneficial.
Right.
The second point I would like to make is when you are doing laparoscopic work, you have a tendency to pull for vision. Okay. So the lower end, when you are handling, you tend to pull on the cyst.
Yes.
And therefore the pancreatic duct sometimes gets pulled up. Okay.
Yes. Yes.
So if you try to aggressively go to the lower end of the cyst, we have had in our experience, people or patients present later on after 5 years or 6 years with pancreatic ductal dilatation and problems. So I think one needs to be less aggressive at the lower end of the bile duct. That is my comment. Thank you.
Yeah, so point taken, but I feel we should be careful of the pancreatic duct, but we have to really go till it tapers. We cannot leave a cyst there. So maybe comment.
I have with experience learned to realize.
Yeah, I got your point.
You can leave a little bit of cyst and burn the cyst wall rather than go with a tug to excite the thumb. That is my view.
Maybe we can get a comment from Bhatnagar.
Absolutely.
Sir. No, so the technique is safe. So we have learned from you only, sir. It's just transposition of the open technique to laparoscopy.
Sir,
so
this is with an experience of almost 15 at King's.
Got it.
So that is why I'm telling you that you are young, you will not see the problems immediately. But as time would go, they will come with episodes of abdominal pain, pancreatic ductal dilatation. So you may find the implications of what I'm talking. Maybe.
I totally agree with you. Only thing for the fresh pass outs and the residents is don't leave a cyst behind. Cystic mucosa behind.
Mucosa can be cauterized.
Okay.
The advantage of the open surgery is that you can do bilateral.
Sir.
And so I personally use the bipolar.
Sir.
But bipolar second fine.
Yes.
The dissection is absolutely accurate.
Accurate.
And you can go down without much study.
Yeah.
What worries me and what actually hurts my senses is the way you cut the edge of the microphone. You know, cutting it with a
Scissor most of the times. It looks little bad on the screen, but that is how it looks on laparoscopy. So it's a magnified vision. So it looks like that. It doesn't. Absolutely. Yes. 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 Sir. Yes. I agree, sir. That is just because in lab, even a little bit of blood will hamper your vision. So sometimes we use cautery in between when you're using the scissor. The cautery is on the scissor. We're using it, and sometimes in a little older child where it might have been a little inflamed, even a harmonic can be used for division. So that is what we're doing. So it depends on what size CHD we find. So if anything, say around in the range of 5 to 6 mm, we like to make it at least a centimeter. So if you find a duct which is 5 to 6 mm, you have to spatulate the anterior wall and you have to do it.
So the technique of enlarging the
Fish mouthing, yes.
So
You can give 2 lateral cuts also. Absolutely. Yes. 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 In smaller children, sometimes the CHD is a little smaller, sir. Otherwise, older children have a good dilated CHD, robust, which holds sutures well. And mostly, as sir said, 5O sutures and thin fine duct, maybe even 6O sometimes may be required. 4O can be used in older children. So that's it. So thank you very much. Thank you.
Thank you for the excellent presentation, sir. Now I would like to call upon Dr. Nitin J. Peters, sir, for a talk on gastric pull-up video demonstration of the surgical technique.
Good morning, everyone. So as this is loading, there are many senior teachers in the hall, and everybody has been, has done this procedure. So it is just my humble experience which I'm presenting over here. And in our department, various consultants are doing various procedures. Professor Ramsamuj and myself, Dr. Munir, we do gastric pull-ups, and Dr. Mahajan, Dr. Prema, they do reverse gastric tubes, and of course, Professor Rao had familiarized the world with the fundal tube, which was also being done by as and when the indications are there. So we've have had good learning from our teachers, and we're trying to do an ERAS protocol for gastric pull-up, which Dr. Sauji has been a proponent of. And that ERAS protocol is basically what we take the anesthesiologist, and we have a consultant who's a neonatologist who looks after our neonatal care. So she actually comes on board for the gastric pull-up care also. And we have a pre-op meeting in every case and decide how the outcome would be to, to take over the baby from the OT and back to the ICU. So we do not put any chest tubes. We are extubating all children on table and no drains in the neck. So if there's a leak, we just open a few sutures. So the children are much more comfortable. And I think we're standardizing things over the last 22, 23 cases now, which we have done in this kind of a protocol. Intraoperative fluids are kept at around 2 to 3 ml per kg, and post-operative 70% fluids with a basic Lasix, a low-dose Lasix infusion, midazolam infusion, and hydrocortisone for 48 hours. So that's our protocol. And we've done around 5 units also. And of course, there are Professor Bhatnagar sir and Sandeep sir are here. The AIMS group has done that and are not doing that anymore for reasons of long-term issues. We've been able to salvage 3 of those children. They are doing well. 2 of them are more than a year old, and 2 children out of those 5 died in the perioperative period. So we have, 3 out of 5 survived in the neonates. Thank you. So we are, it's a standard procedure. We all do that. So esophagostomy, gastrostomy, something we do differently is we do a esophagostomy on the right side. It's been a standard of practice in our institute. We have been doing it for a long time. I really don't know the reason why we do it, and we're comfortable with it. Everybody says that, esophagus on the left side would come out easily. So we are doing it on the right side. So there are a lot of people who say they want to do it on the left side. Actually, patients we get from outside, we get a left-sided esophagostomy. So, and at around 9 months to 1 year of age, we do all the perioperative workup, including all the workup of Rectal, and then good dye study to look at the stomach anatomy. And all our cases, the first one is the first neonate we had done, and the rest of them are older children. I did not, I thought it was just a video thing, so, but I didn't do all the other things. So I'll just. Yeah, so I'll just move this a little fast. It's a longer video. So once the esophageal stump is nicely mobilized, and then we go towards the abdomen, open the. Usually, more often than not, we find adhesions to the liver and the anterior abdominal wall, which is common. So slowly, meticulously, we release those with blunt and sharp dissection. We see if we can get a plane. Otherwise, a harmonic comes to the rescue most of the times, and we take care of, do this step with the harmonic. And then the hiatal dissection towards the hiatus, when we go, we carefully hook both the cruras, bring it out separately, pull the cruras to each side. Good retraction is given, and then with the use of cautery, we slowly mobilize the lower stump. Once the stump is done, of course, it's difficult to have a video of the posterior mediastinal tunneling, so that's obviously not there. So posterior mediastinal tunnel is made, and at that time, what we try to do is stay right in the midline, ask the anesthesiologist to bring the lung down. And so, and we've, in these 22 patients, in one child, we had to put a chest tube in spite of lung down and staying in the midline, we had a pneumothorax. But in the rest of them, we were fine. We did not have any problems there. Yeah, and so I'll just show this step. Once we close the stomach, before closing the stomach, we put in a feeding tube, copiously with saline, wash the mucosa of the stomach so that all the, it's taken care. We do this one day before also, and start one day, the night prior to this, the gastric polyp also, the family is asked to wash the stomach with saline. And we do this on table also. After the closure of the stump, this stomach is. After the tunnel was made, the stomach is usually, we make this tunnel often, we're very comfortable with it. Sometimes you may have some arrhythmias and problems, but more often than not, you take time and do it slowly, and things come out easily. The stomachs get pulled up quite comfortably. Without any tension. Put the stomach there and then do a standard esophagogastric anastomosis. I do not have data on all the children who have undergone gastric transit studies and follow-up contrasts. So some of them are still pending. So I think maybe in a couple of years, I'll be able to show that data to everybody. So this is the one of the post-op children. So you can see no chest tubes. So the child has 3 tubes. One is a jejunostomy, one is a nasogastric tube, and the third one is a catheter. Catheter is removed in 48 hours, and the nasogastric tube after around 7 days. So they're all managed in the ICU but not ventilated, and we are quite happy with the protocol we are using. Thank you. Okay.
But nowadays,
Correct, sir.
that is why now also point of technique.
I think I'm loud enough. Another point of technique is when you are creating space in the mediastinum. My preferred instrument for that is my finger, because I just keep my finger on the vertebral bodies, and that is the safest way of producing that tunnel, that space, without risk of injuring anything. So you can do the finger dissection from above and from below, and when both your fingers meet, you know that you have enough space for bringing up whatever you want to bring up, the colon, the stomach, the tube, or whatever. Philosophically, I think I prefer to use the stomach pull-up as the last resort, because I also believe that it is the most unphysiological way of replacing the esophagus.
So, sir, we've done it in the first few cases, and after that, we actually in those few cases we had a bit of a problem. I mean, not related to pyloroplasty. Then we discussed it with our senior colleagues, and I've not been doing pyloroplasty after gastric pull-up.
That's fair enough. I think there's a lot of literature available whether you do it or not. I mean, you try doing pyloromyotomy, you end up doing pyloroplasty in most of those cases. The only point which I wanted to make was last 20 odd years, I've done all retrosternal and not through the mediastinal. And my operating time has never been skin to skin. I'm talking more than 1.5 hours. The problem was that we didn't have the great ICU care and all that, so we needed to extubate this patient. So no chest tubes for us, but retrosternal.
I also do gastric pull-ups more often than not. Choice of route depends on what the patient had initially. So pure atresias, posterior mediastinal route, but if there was a leak in a TF repair, then usually we prefer retrosternal, because then the mediastinum will be frozen. The other thing which we have started doing for a number of years is if there is a leak in a TF repair, then instead of doing a gastroscopy, we do an abdominal esophagoscopy. So at that time only we pluck out the lower esophagus and bring it out. Advantages are that the stomach is virgin, it has not been touched, there is no gastroscopy wound to close, and lower esophagoscopy is a non-refluxing conduit where you don't need a gastroscopy tube or a button. So mother puts in the tube, NG tube, feeds the baby and takes it out. It's a non-refluxing, like a retort. So it's easier to manage at the time of the pull-up also.
So just can you elaborate a little bit on the abdominal esophagostomy?
So
in
in
the sense, it's like a stoma?
Sir, yes. So in case this we just started doing it somewhere in early 1990s. So when there is a esophageal anastomosis done for TF patient and it leaks, so what do? You go into the chest, close the lower esophageal stump, come into the abdomen, do a gastroscopy, and go to the neck and do an abdomen and esophagoscopy. So what we started doing was we were not opening the chest. We would do a esophagoscopy, and then we would go to the abdomen
open, look at the G junction, loop it, and dissect the lower esophagus without opening the chest. And through that hiatus only we could do a decortication or whatever pleural toilet and bring the lower esophagus down. So lower esophagus travels on the undersurface of the liver. So when the stomach distends, it compresses the lower esophagus against the lower surface of the liver. So it becomes a non-refluxing. It's a very small opening in the abdominal wall, esophagus opening, which takes in a 5 size or 6 size feeding tube. And wherever the mother feeds, it puts in a feeding tube, feeds and takes it out. So the gastrostomy problems are taken care of. The nursing is very easy. And the most important thing is the newborn, when there is a leak and sepsis and everything, you don't open the chest again. So the morbidity is much less. And it works very well. We reported this in, I think, 1996. And we have been doing this very regularly.
Yeah, I did last week, so I just wanted to know something like this. Yeah.
I've been doing the same, but the only issue that I've had sometimes in a pure esophageal atresia when I do this, and the left lower liver is a little big, so I ended up in having some bleeding while the assistant is kind of retracting the liver while you get that lower esophageal pouch down.
So we don't prefer to do it in pure atresias, because in pure atresia, stump is very short, and invariably what you bring out will be near the very G junction. So it is non-refluxing, and that causes problem. So in pure atresias, the stomach is also small, the lower stump is also small. We do a gastrostomy. But in TFs, where we've done an anastomosis and it leaks, the lower stump is quite long.
So
and
you keep the entire length of the lower
stump,
esophagus
except the tip.
Yeah.
You flip the lower esophagus over the stomach. So on the undersurface of that stump is the stomach, and on the upper surface of that is the left lobe of the liver. So when the child is being fed, the stomach is full, it pushes it against the left lobe of the liver, and there's the same anti-reflux mechanism as you have in the ureter. So it's a continent esophageal gastrostomy.
Esophageal feeding.
I appreciate your presentation.
Sir.
There were 2 patients where we did gastric pull-up who had vascular anomalies. One had an aberrant right subclavian coming from the left side, going to the same area. And the second one had a double superior vena cava. So my heart was in the pelvis while I was doing the dissection, as sir said. And now while talking, I have realized an idea that I could use retrosternal route for these patients. But sir, do you have any technical tricks when there are vascular anomalies like that? Because we had to literally take the consent of death on table while doing it. So are there any, like one of the things that you said, stick to the vertebral column that we did. But in spite of that, we could feel a different kind of situation while we are dissecting with these vascular anomalies. So is there any experience of any person with such a problem? And has anyone landed up with situations where it has bled while doing this?
I think in vascular anomalies, don't do the posterior intestine. Don't do. Retrosternal is so easy to do. And long-term outcomes are same, whether you do intestine or
Yes, sir. Vijay? Dr. Vijay. Vijay.
Dr. Nitin, nice presentation. Only 2 things. What we had do our center, we usually do retrosternal pull-ups. But if patient has undergone any cardiac surgery, then we use the posterior mediastinum. And what Sanjeev sir also said, we using the abdominal esophagostomy, especially in the esophageal atresia. We need not to open the chest, but in these cases, we need if we did not bring the lower esophagus down, then we have to toilet the mediastinum and do the thoracotomy. So in these cases, we do in the case with the leak, we usually do abdominal esophagostomy. But in the cases of pure esophageal atresia, we do gastrostomy, so simple gastrostomy. So this is our
right, sir. Chairman, sir.
I have experience of opening up patients who are retrosternal gastric pull-up later on in life for cardiac surgery. It doesn't cause any problem. stomach is very, very utilized, and as soon as you do the stomach, they always fall out, and you can put the stomach to the side and go ahead with the participation. It does not fall.
Last comment by Yogesh.
Sir, in the past, when I used to do the mediastinal route, and at times used to find difficult to pull the stomach through the incision. So to have a better exposure there, and it is described in literature, it's not my giving. We excise the sternal end of the clavicle on the left side. So that gives you some leeway and you can get the stomach up to most of the esophagus.
Chairman, sir, may I make a comment? Just one comment? Yeah, is it possible? So we do the leak management a little bit differently. I think what we have, there was a paper a couple of years ago from our center. We also don't open the chest. We try not to do a esophagostomy also. If it's a very bad refluxing leak, then we do a gastrostomy and a transgastric feeding jejunostomy. And we keep feeding these babies, and we've seen that almost 70% of them respond to this, and the native esophagus is preserved. Yes, later on we've had to do stricturoplasties. That has been a problem, but like sir said, that the physiological esophagus, we try to preserve it as much as possible. So that is one of the ways we manage our leaks in around 30-40% of our patients who don't need this problem. We measure the feed every day, and we take a decision based on if more than 20% of feed is coming out of the chest tube over a period of 2 to 3 days. And if more than 20% of feed is coming out of the chest tube, we go in for a gastrostomy and a transgastric feeding jejunostomy. And so the baby is fed nutritionally, and then things improve. And now with our neonatologist, I think we are managing neonatal TPN also quite well. So those problems are not so much. Thank you, sir. Okay.
Some of them, very few of them, most of them will die also. So we have to literally keep them. We have done that. But ultimately, 40-45 days are part of this day. So I think very early on we decided that a lot of them, but majorly, not minor. Majorly, the patients who have major need for the chest, I don't know, thorax, lung, thorax, all those who are really.
Okay, thank you everybody.
Thank you.
So we like to wish Professor Upadhyay, who is the teacher of teachers, a very happy birthday today. So sir, if you're watching on YouTube, a big happy birthday to you. I don't know how old is he today, sir?
I think he's in the
90s.
90s.
So wish him a lot of good health and birthday wishes. Thank you very much.
Moving on to the fourth presentation. I think fourth in the series is choledochal cyst technique, point and technique by Dr. Anjan Dua from AIMS. Okay. So which presentation is next?
Thank you, sir. Now I would like to call upon Dr. Ankur Mandalia, sir, for delivering a talk on Pediatric Robotic Surgery Program at SGPJMS Lucknow, the journey so far. Over to you, sir.
Good morning, chairpersons. So I'll just share briefly our recent experience with robotic surgery. We started doing robotic surgery in February. So this is more for younger surgeons who want to go into this field, and even for other young faculty who want to start this at their institute. I'll just take you through what we experienced at our center. I have no disclosures. So the first case of robotic assisted laparoscopic in children was in year 2000 when Meninger et al. Performed 2 cases of robotic Nissen fundoplication, and it was published in 2001. In March 2002, Peters et al. Performed the first robotic pyeloplasty in children. Since then to date, more than 70 different pediatric robotic surgical techniques have been published. So the advantages of robotic assisted laparoscopic surgery, we all know this, there is a 3D stereoscopic and highly magnified view. This is much better than your standard high definition laparoscopic view. There are wristed instruments with 7 degrees of freedom. It gives much more ease to work compared to your standard laparoscopic instruments. There is tremor filtration. So in long surgeries, especially in laparoscopy, there's a lot of surgeon tremor. There's absolutely no tremor when you operate on the robotic platform. There is motion scaling, more refined hand-eye coordination, superior suturing skills. I'll just show you a brief clip of that compared to what we saw earlier in the laparoscopic suturing. Operator controlled camera movement. I feel as a minimal access surgeon who do this is one of the most important factors other than the magnified view. The camera assistant in long laparoscopic surgeries like coloidal surgery, lot of coordination is required with your cameraman. You really need a good cameraman to do complex laparoscopic surgeries. But Robo gives you surgeon control for the camera, which is unparalleled. It's a breeze to control the camera on the Robo. There is an element of the fulcrum effect, as I said earlier. So robotic surgery in children is now as well established in most developed countries. Some of the children's hospitals in the West have 3 or 4 robos even in USA and Europe. But its growth is clearly slowed in developing countries like ours. So what are the factors? The most important factor is the cost of the initial purchase and equipment maintenance. But I believe now Intuitive is going into lease with various hospitals, and they are working on a lease model where you don't have to purchase the robo upfront, and there is a model where the patient pays a little extra, the hospital pays extra, and on lease they can give you the robo. Lack of financial coverage for pediatric procedures. Obviously, these procedures add an additional cost right now because there is monopoly by Intuitive. So the consumables are very, very expensive. Most cases in children are low volume, complex reconstructive procedures. So if you buy a robo for a standalone children's hospital in India, you will take a very long time to recover the cost. So at most centers, the plan is to buy a robo, like in SGPGI we have a robo, and it is shared by all the specialties, adult specialties, pediatric specialties, and then only you can recover the cost. Equipment is primarily designed for adults. So right now the XI system has only 8 mm ports and 8 mm instruments. Earlier SI model had 5 mm instruments, but in the XI you only have 8 mm. So you have to put a minimum of an 8 mm port. And obviously we all know there's a small working space in children. So these robotic arms and the instruments are really bulky. So you cannot do it beyond a certain lower age limit. So I'll just describe briefly the process limitations and difficulties faced in the inception and implementation of the pediatric robotic surgery program at SGPGI. So in 2019, the Da Vinci XI robotic system by Intuitive was installed in the main OT complex at SGPGI. In the same year, initially 2 surgeons from 4 adult departments, that is urology, GI surgery, cardiothoracic surgery, and endocrine surgery, were trained by Intuitive and certified by Intuitive. So you have to get certified by Intuitive to be a console surgeon. You cannot control the console without Intuitive certifying you. So initially 8 surgeons from 4 departments were trained, and the weekly surgical slots, that is you have 1 slot every day from Monday to Friday in SGPGI, were divided between these 4 departments. And Intuitive in the initial cost also gave initial 200 cases free, which were divided between these 4 departments. That is 50 cases were free. First 50 cases for each department was free for the first couple of years. So we are a high volume center performing advanced minimal access procedure in children and also training our residents for the same. We also have a fellowship in minimal access surgery. So right from when the robo was installed, our department was requesting the administration to get the faculty trained and give us a slot in the robotic surgery program. And it took us 2 years, and I'll really like to mention Professor Basant's efforts here, because of which finally the administration gave way and agreed to train the department of faculty and give us a slot. So in January of this year, 2 faculties from our department were trained and certified by Intuitive. And in February of this year, Uttar Pradesh first ever robotic pediatric surgery was done in the 3rd week under mentor, which was Professor Ravi Kanodia from PGI Chandigarh. So in March, we operated the first case without mentorship. And in the last 5 months, another 13 cases have been operated. So our limited experience has been of 15 major robotic cases till now. So what is the training and certification process? This question is asked by a lot of fresh pass outs, MCA students, young faculty. So what is the process? So the process is, first, your hospital should have a robo, obviously. Then the administration has to agree for you to undergo the training, as in our case. So once they agree and the Intuitive people are ready to train you, first they ask you to sit on a simulator. So the robo comes with a simulator, which is again very expensive. You don't have to buy the simulator, but it's very good to invest in the simulator, because without that you cannot train people. So you simulate on the console, then you do dry drills, like all the various exercises. Then you observe procedures in OR, you can even observe in other specialties, people who are already doing it. Then you do a wet lab training. Wet lab training is on pig model. For that, you have to go to Kochi. Right now, there is only one center in Amrita, Kochi. That's in their veterinary college. And it's a 24-hour, not a 24-hour, one-day program. They call you at 8 o'clock in the morning, and you have to do the wet lab training till 8 in the evening. And it's a very rigorous process. Like they train you on various procedures. They make you do an hysterectomy and nephrectomy and many surgeries on the pig. And then they finally certify you, and you can come back and start operating under a mentor, and then you take over. So simulation, what is simulation? It's mastery learning. It involves deliberate practice and experimental learning. So this is the simulator, how it looks on the robo. Once you sit on the console, you are made to do all these small exercises. You are made to move the camera. You are made to like coagulate vessels and do suturing. There are also models for simple procedures like cholecystectomy and nephrectomy, and so it gives you a feel of the console. You can control the robotic arms, you can control the camera, and you have to do this simulation for a minimum of 18 to 20 hours before they send you for the wet lab training. So this is the Amrita Institute. We did this, and then we called the mentor. So mentor for us was Professor Ravi Kanodia from PGI Chandigarh, who very graciously at a very short notice agreed to come to our department and mentor 2 cases for us. This is him with our director, Professor Deeman, and this is our departmental picture with all the residents and in the OT. And he showed us each and every step. He was there all the way, and he also made us do few steps in the initial cases. So there was a wide coverage in the media about that first case, and we could do a lot of it. So I'll just briefly go through what are the operative steps for people who have never been inside a robotic OT. So this is, I'm just showing 2 of the cases which we commonly do. One on your left is this is the choledochal malformation, and on your right is an achalasia. So compared to ports for laparoscopy, where you have to triangulate, the robotic ports go in a linear fashion. It has to be in a straight line. So for choledochal, suppose for laparoscopy, the umbilical port goes here, the vision port, and you put 2 ports here. But in robotic, these 3 working arms are in a straight line. And same for achalasia. You're going to work here. This is your target organ. All these 3 are going to be in a straight line. Always there is an assistant port for in and out of the suture, in and out of the suction. This is how the ports. So the robotic ports. This is a picture after we finish. So there is a drain. But you initially, so the initial port insertion is same as laparoscopy. Most of us use open technique and put the first port, then put the other port. So these are the robotic ports, these steel ports, these are reusable, on which the robotic arms will attach. These are not disposable. So these come with the machine and you can use it for 50, 100 cases. And one assistant port is required. Here we have put a bigger port for the stapler. So I'll just show you a brief video of the docking. Docking is when once you have put the ports, the robo comes on the patient and you dock the arms to the ports. So this is a video from YouTube. Now once the ports are in, this machine, this is the XI robo, it comes, there is a targeting system. They target it on the optical port, and once they put the camera now, and they see the vision inside, and then you there is a target marker which you put on the target organ. Like if you are doing a choledochal, the target marking will be on the choledochal cyst. And now it's ready. And after this, at the bedside, there is a scrub nurse and there is a assistant surgeon on the bedside, and the console surgeons can sit on the console after this and they can start operating. So this is just a view from our OT. This is one of the cases which we are doing. So this is how the ports are docked. We are doing a procedure. So the arms are moving, and there is a scrub nurse. There is an assistant who is doing some things through the assistant port, in and out of the suture. Some suctioning in between is required. And we can see we have a dual console. So two consoles are there. Two surgeons can sit on the console simultaneously. This is one of the surgeons doing the surgery and moving those arms. This is one of the initial cases. We are not very ergonomic in this, but slowly we have improved. And this is how the ports look. There is requirement for spacing between the arms so that they don't clash and stuff like that. There are various things for that. I'll just show you brief video of Hellers and brief video of choledochal. So this is a Heller door which we did. You can see the ease of the articulating instrument. In lab, the instruments are absolutely straight. So you have to make an effort to do the same thing in lab. It becomes little easy. People who do it lab will just find it little easier. Even people can, they say they can move, you can move directly from the open surgery to robotic. You really don't need to go through the laparoscopic learning curve. So steps are same. You do the myotomy, then you do an anterior partial door fundoplication. So you can see even in the recess, like we are repairing the crus here. So even in those recesses, the wristed instrument goes very easily, very nicely. This is the left side of the myotomy. We are fixing the wrap to the left edge of the myotomy. Now we are fixing it to the right edge of the myotomy. And you see the ease with which it goes. It really is very comfortable. You are sitting in a very, very ergonomic position. The view on this 2D screen doesn't do justice to the 3D view you get on the console. You really have to sit on the console to see the view for yourself. Just a very quick video of the choledochal cyst. This is a cystic choledochal cyst, I think a 1.5-year-old child. Usually they give this scissor, which also works as a monopolar, and in the left hand, the Maryland also works as a bipolar. So just the steps remain the same. You dissect it from the right hepatic artery, you cut the CSG at the correct level, and the cheatling, we were just talking about the cheatling in the last video. Again, we do Roux and Y, so there's a Roux loop made outside. We have to undock once for that. And this is just to highlight the ease of video compared to the laparoscopic suturing you saw earlier. It has to be done to be really understand the difference between laparoscopy and robotic suturing. But it's a very ergonomic position. The sutures, you can take very fine sutures. The view is excellent. It goes very smoothly. So after this, once you have finished the procedure, is the undocking. Undocking is nothing but you have to remove the arms from the ports. Undocking just takes 3 to 5 minutes, 2 to 3 minutes, I will say. Just the robo goes away. The ports are there. You close the ports, put the drain, and you come out. So this is the 15 cases which we have done. So we have done 13 cases of choledochal cyst, 2 cases of achalasia, Hellador. We record operating times, console times. Most of the patients did well. We didn't have to convert in any of these patients. Hospital stay was similar to the laparoscopy group. Didn't have much advantage there. But in some of the cases we had to do HD. You'll see, I said earlier we do HD. This HD was done, one as part of the first case which Dr. Ravi Kanodia did because he does a HD. 2 other cases, the dissection took a really long time. They were the initial few cases. So we couldn't do the HD as it takes much longer time than the HD. So we did HD in a couple of cases. So this slide is what it costs at SGPGI. So 1,19,000 is the extra cost other than suppose we do the case laparoscopically. So how it comes is there are 4 arms. Each arm drape is around 5,000 rupees. You spend 20,000 just for the drapes. There's a column, center column drape, which is 5,000. And all these 4 instruments are in the range of 20 to 30,000 rupees. So how it works is the instrument costs around say 3 lakh rupees. Every time you use it, it is counted as one on the computer. You cannot manipulate it. You cannot do any jugaad. It is counted. After 10 cases, you have to use a new one. You cannot use it for 50 cases like we do in endoscopic stapler or something. And you have to throw the instrument away, take the next one. So suppose a 3 lakh instrument divided into 10, 30,000 for that instrument for every patient. So this is the cost for say a choledochal in addition to what you do laparoscopically or open. So in conclusion, the hurdles in implementation of robotic surgery in children are the high purchase cost and the equipment maintenance, high cost of training and certification of the surgeons, availability of OT slots in a busy public or private sector hospital, and other considerations for pediatric robotic surgery in addition to this are the lack of financial coverage of the procedures by insurance companies. You really have to see the cost benefit analysis and the suitability of the child for a robotic procedure in terms of age, weight and primary diagnosis. Thank you very much. I would like to thank all our team for this presentation. Thank you very much.
Excellent presentation. Like we are in the process of having a robot BHU. We are having administrative discussion. The first and foremost question which we are being asked is like you highlighted the economic thing of the surgery. How patients are going to afford it? How we'll be able to run the program successfully in future when we are having the robot, and how to get the cost out of the surgeries. So how are you managing patients?
That's the first and foremost question whenever anybody asks. So I think your clientele and our clientele are pretty similar, like UP and Bihar and our surrounding states. So most of the patients are not able to afford this. Say 1,19,000 is over the 80-90,000 which they anyway spend in SGPGI for a choledochal. So the total cost goes even higher in our institute. It goes to 1.8 lakhs, 1.9 lakhs. So what we do, luckily what we have is the government, if you send an estimate for an elective procedure, the MP or the MLA or the CM fund can give fund for the procedure. And usually this government and even the previous government was very good that they support pediatric surgeries. And once an estimate is given within 2 to 3 weeks, you get the fund in their patient account. And I think out of this 15, 10 or 11 have been done by the government fund. Only 3 or 4 were done by the patient's own money. And it was done in patients who were affording. We do get patients who can afford 2 lakh rupee surgery. So,
I think that point is very taken. When you send an estimate around 2-3 lakhs, the money will come around 50-60,000, 1 lakh. So
yeah, I know.
Getting administration to like budge upon that fact that we are going to have a program which will be run by the funding of the government on a patient basis, that's the biggest hurdle which we are finding right now to get our robot through.
Yeah, so estimate you have to give for 5 lakh rupees. Yeah, so then only you will get 2 lakh rupees.
Sir, I have one question. Sir, how much degree of freedom is there for the movement of this tip of the instruments?
Complete freedom, absolute freedom. Like you would move a wrist, it moves all 360 degree. There is 7 degrees of freedom. So you can move it any which way. Even a human hand cannot move in that much freedom.
Sir, I have a solution for the previous question, sir. Sir, from Patna. Sir, I have a solution for you for your finance. The degree of freedom that has been in the robotic surgery, if that freedom, degree of freedom is provided in the laparoscopy instruments, the degree of freedom and finance will cut down, and we can have that economical solutions.
Yes,
I think solution has been there.
Okay, the degree of freedom, I think you are telling about the few instruments which are
developed by IIT Kanpur and IIT Kharagpur.
Yes.
So we have to tie up with them.
Yeah, just short comment. So one of the fewest drawbacks or limitations of robotics is that you can attempt only single quadrant pathology. If you have to do double quadrant pathology, you are supposed to undock, and that is counted as 2 patients, and that's so. I think that is a situation where I think laparoscopy still outsmarts robotic. For example, you have bilateral UPJ, you can do it laparoscopically, the same port. It's not possible with a robot. And that is the reason you have done HD in few cases, because doing HG robotically is near to impossible. So you can't do HJ. HJ you cannot do without undocking the robot.
Yeah, in children, intracorporeal JJ is very, very difficult. And as you said, you cannot look down.
Yeah.
You have to look up. That is the problem. Munir is right that the robo, because you target it for the polydocal, like the cyst, if you want to do the JJ and look down, your arms are already targeted for that. So you cannot do the JJ intracorporeal. You have to either undock and target again. And the space is so less that you cannot do the JJ inside. So we undock in all these cases, do the JJ outside, dock it again. But what I'll say is that docking actually takes very less time as you do robotic yourself. The docking takes hardly 5 minutes. So it's just an extra 10-20 minutes. It's just again the same philosophy of HD versus HJ. So let's not get into that.
Why is that it's counted as 2 patients and adds to the cost actually?
Yeah, Dr. Basant, please. Yeah.
Hello. One more thing. In robotics, there is targeting of organ. You cannot manipulate. If you want to do JJ, you have to target that particular area. We need it out.
Yeah, Anjan, last comment.
Yeah, thank you, sir. Ankur, very nice presentation. And
one more thing, sir. One more thing, sir.
He's speaking. Anjan is speaking. Just wait.
Point about the economics and the financial aspect. There is a made in India version that has already been, SSI mantra version, and it has already been installed in Rajiv Gandhi, and that has possibly supposed to cut down the cost markedly, and because that is because of the monopoly of Intuitive that we have to pay. There is no other option. But the mantra version, the made in India version, is supposed to take care of that. I'm not aware of the exact finances, but it is supposed to.
Last comment I'll do is robotic is good for the surgeon. Whether it is good for the patient or not, we don't know. True. Because you can do the same thing laparoscopically. However, I mean, if you have opportunity of doing robotic surgery, you must learn, because it is the future. There is no question about that. In complex pediatric laparoscopy surgery, I think robotic will play a big role. The simple surgeries anyway will continue to be done laparoscopically. Thank you very much.
Thank you, sir.
Sir, I'm in the favor of laparoscopic surgery, because while suturing or taking a dissecting a tumor, whether it's a soft or hard, the aesthetic sensation that we feel in laparoscopy, we don't get in robotics. So I feel that laparoscopic surgeries are always better than this robotic surgery, provided the degree of freedom is we get due to the innovations and some technology advancement in laparoscopic surgery. But I am in the favor of laparoscopic surgery, sir. Your surgery was wonderful, sir. Thank you, sir. And Ankur, sir, you have done a wonderful presentation.
On coffee.
Thank you, sir. Now I would like to call upon Dr. Nitin J. Peters, sir, for a talk on concomitant liver and retrovesical hydatid cyst management. Over to you, sir.
Thank you, organizers, for allowing me to do both these together, because we have a flight to catch. And is this small video clips. The first one is basically the advantage which Dr. Munir was just telling, that organ-based focus is not there in robotics. So that is somewhere laparoscopy has an upper hand. And we found this, we had this patient with double Hydatid. So I'll just show that. Yes, thank you. Yeah, so we had this patient who presented with the Hydatid, which was in the retrovesical area, and one lesion was in the liver. So then it was thought that why don't we go in laparoscopically and target both organs. It was a 6-year-old boy who presented with pain abdomen, and clinically exam was normal. Even though Hydatid serology was negative, the CT had a very clear picture of a Hydatid in the retrovesical area. So yeah, this is the video of, it was quite an inflamed cyst, and we take all precautions like in open surgery, use 10% betadine solution. The gauze pieces were all soaked and put, and a glove bag was used to retrieve the endocyst. Once that was done, the pericystectomy was done using a harmonic scalpel, and the retrovesical aspect was taken care of. You can see the dense adhesions between the pelvic organs and this retrovesical Hydatid. This was the other lesion which was there in the liver, segment 2 and 3. So again, adhered with the omentum, was removed, and the same principles of Hydatid surgery, as colicidal soaked gauze pieces were kept inside. The cyst was punctured, and this did not have much fluid because, like you saw on the preoperative CT, we tried to aspirate, didn't get anything much. We normally use a Shiba needle. Actually, we use a deflux needles. We have kept all of those deflux needles back, and we use that deflux needle to aspirate this cyst. Then we de-roofed this with a harmonic and removed all the infected endocyst in this patient. So advantages of laparoscopy, obviously started orally on post-op day 1, discharged on 3. It's a 2-year follow-up with no recurrences. And we managed to send this as a letter to editor in one of the journals. Thank you.
Thank you for nice presentation. Sir, question? Thank you. Very nice presentation. One query which I would like to know, that this pericyst is nothing but a host reaction.
Yes, sir.
Is not related to the parasitic cyst. So is there need to take out, or you just leave it? God, in the liver, if you take out that Hydatid cyst, you are not taking care of that pericyst. But why that in the retroperitoneal area and other area, as you shown this video? Thank you.
Thank you, sir, for the question. So I think routinely what we're doing, we're de-roofing in livers also. And even in the lung, we are doing a similar, those procedures. But over here, if you saw that the cyst, the pericystic inflammatory area was all stuck very badly to the area. So that's why just the de-roofing and making that a little bigger opening so that there was no collection there. That's why it was done. 10% betadine.
Sir, question. Okay, if no, none of the other questions are there.
I will ask.
Okay.
By the time this other one is loading, very often I have seen this being reported.
Yes. Yeah. So I take your point, sir. So if essentially, I think the choice word was incorrect, and a de-roofing is the thing which I meant to say. Yeah, I agree with that, sir. So there's a disclaimer. This video was presented at the online IAPSCON held 2 years ago, I think. So this was an interesting case. We had a patient who presented with a bladder mass. And we thought this was a rhabdomyosarcoma, like the first thought would go in that process. But, sorry. Yeah. So, This patient was worked up like a RMS, but eventually it turned out to be an extrarenal Wilms of the bladder, which is a rare entity, and it is described in 1961. And what is happening is that these children, this is a pathologist who brings out the diagnosis. This was a 2-year-old female child with difficulty in micturition and retention, presented exactly like RMS. The MR urography, which was done, showed a bladder mass. Cystoscopic biopsy was done. And actually, once the biopsy was done, the pathologist gave us a WT1 and a PAC-8 and a faint Desmond positivity and diagnosed this as a bladder Wilms. So once the bladder Wilms was done, a standard PSYOP 2001 protocol of 2 drugs was done initially. However, after 4 cycles, there was not much response. So the oncologist decided to add the 3rd drug, and we got a better response. This was the preoperative CT urography. So preoperative cystoscopy had shown that both ureteric orifices were clear and the small bladder was there, a small tumor was there at the dome. A standard 3-port laparoscopy was commenced, and we looked at the resectability options, and we wanted to see whether we'd be able to take it out. This was a female child, so we looked at the female genital organs, and once all that was done, we started doing the peritoneal, taking on the peritoneal reflections, and we had filled the bladder partially and kept the assistant was tugging on the catheter. Once we go into the bladder, I'll show that step. Once the peritoneal reflections was done, a good 1 centimeter margin marking was done using a cautery. So we used monopolar as well as harmonic. And as some reports are coming in that a harmonic dissection in tumors may be better because the thermal dissipation is less and the pathologists may have a easier time reporting. I don't know, maybe Sandeep sir can tell us whether that is a fact to be looked at. So once we came inside the bladder, we started going inside the bladder. The assistant evacuated the urine, and the bulb of the catheter was, side tugging was there to maintain the pneumoperitoneum. And we initially thought that we'll do an intraoperative cystoscopy, but since it was just on the dome and we were quite clear that we are able to take out the entire tumor. Yeah, this is the time when we've entered the bladder. And then the specimen, once everything was out, was again retrieved in a bag. We made sure that this tumor did not touch anywhere else in the peritoneal cavity. Yeah. So we looked at both the orifices, looked for any other tumor residue in the bladder. Once it was not there, we went ahead and closed the bladder in a standard 2-layer way, like you would do it in the open surgery. And this child is now 1 year, more than 1 year post-op. She's done well and is comfortable. We've managed to publish this. And a big thank you to SGPGI team. We had a great time here. And we are really happy to be here from all of us at PGI and other institutes. Thank you so much. Yes, yes, sir.
Operative marking of the from inside the margin you told. While marking from the outside is a different thing, and while operating, once you go into planes, you might go a little bit oblique. So cystoscopy intraoperative would have been better in this case. What do you think?
I thought so in the retrospect that probably if one of the other surgeons could have done a cystoscopy, maybe better. We got a tumor-free margin, all right, but yes, that would have been probably a more scientific way to do it, I think. And the other thing which was missed out on this was the lymph node sampling, which there is no standardization of an extrarenal Wilms. Where do you sample the nodes? So the preoperative radiology did not show any iliac vessels. That's where we looked at. But I mean, it was a rare case and I did not do any lymph node.
So how did you stay?
Sir?
How did you stay?
Yes, so I'm at a loss for that because we don't have a lymph node sampling here.
If you not done lymph node taking, then you must treat it as stage 3. First, you can have a great data.
Correct, sir. Correct. Yeah, that was a drawback which I
Nitin, did you give the holocommon radiation or just chemotherapy alone?
only chemotherapy, but Sarin sir has a point that it was not staged accurately.
Yeah.
So that is a fallacy in this case.
Okay.
Thank you.
Thank you.
Thank you so much, sir, for all the excellent talks. Now I would like to call upon Dr. Peutz-Jeghers, sir, to deliver a talk on laparoscopic management of missed complicated case of SMA syndrome. Over to you, sir.
Thank you again. Again, a disclaimer, this case has been presented at BAPES UK in 2019. This was in a very early days of my career when I had just joined as a faculty 2 years. A case had come at 17-year-old boy had presented to the emergency room for the first time with symptoms of acute onset pain in abdomen and bilious vomiting for 4 days. The amount of vomitus was copious, and patient was thin-built, tall, and had vitals and stable vitals. The unusual thing is there was tenderness all over the abdomen, and which was more pronounced in the epigastric region. Biochemical and hematological parameters were normal. On X-ray abdomen and ultrasound, it was not contributory for the symptoms that he was having at that time. So we went ahead and did a CECT abdomen. However, CECT abdomen was, it was evident that there was a dilated stomach and a dilated D1 and D2 with abdomen narrowing at the level of the mesenteric vessels. And there was no obvious perigastric leak noted at that time. Stomach was fully distended. These are the sagittal images which are showing the distended stomach, D1, D2, and a narrow outer mesenteric angle. So we had first decided to monitor the child in the ward to look for it was the first presentation of a superior mesenteric artery syndrome. So, but in the ward, the patient still had a large amount of bilious output from the NG and was having persistent pain, and it was not resolving. We went ahead with a laparoscopic for the management of the patient. So, this was what I found at the laparoscopy. There was something near the diaphragm and a very small and thin purulent fluid, but a very small amount in the pelvis. But we I first time went ahead with the standard, first diagnosing the condition. There was dilated D2 and D3. The other factor which I was worried was about malrotation or a volvulus, but the ligament of Treats were left to the spine and left to the SMA. So we decided to do a duodenogenostomy for this patient. After ruling out all the other factors which can lead to the symptoms. Cauterization of duodenum was done with a blunt and sharp dissection of the D3, mostly the D3 part, which was required for surgery. So the duodenum is mobilized. I could visualize the pancreas. umbilical tape with marking was used to mark the length of the cochlear duodenum so as to facilitate the anastomosis with the endogia stapler, so that there is adequate length for it. Jejunal loop was identified, which was free, which could be freely brought towards the duodenum, and it was found to be around 20 to 25 centimeters from the DJ, which was very free to reach there. The initial sutures, ceromuscular sutures were used to mark the incision over the jejunum. The first stitch was taken at both the ends of the incision between the duodenum and the jejunum. Again, a verification was done for the length of the adequacy of the segment. And this is the duodenotomy and the jejunotomy, and endogia stapler, linear stapler 55 mm was used. The enterotomy was sutured with the interrupted sutures. I am a left-handed surgeon, so orientation might be different for most of the right hand. That is the problem with my camera assistants also. And after completing the anastomosis, I went and saw what was this, and it was, there was a lot of bile and adhesion of the stomach to the diaphragm. And there was a fundic perforation of around 3.5 to 4 centimeters, which was missed in the initial investigations. It was repaired with interrupted sutures. A drain was put before concluding the procedure. So orals were started on post-op day 3, and patient was discharged on post-op day 5, and patient is asymptomatic and follow-ups and is even gaining weight now. Thank you.
Wonderful talk, sir. Sir, I have a question, sir. Sir, post-operative period.
Yes. Okay. Carry on, please. Yes. Please.
Yes.
Go ahead. Please ask the question.
Sir, I have one question, sir. Sir, you said patient was wonderful and your dissection was very wonderful. The patient operated on orals on 3rd and 5th day discharge. Patient was such a sick patient. I want to know the post-operative course for the first 48 hours and abnormalities that have been occurred in electrolytes.
Biochemistry was patient was maintaining the normal values.
So you said that the patient had 4 years, patient was suffering from bilious vomiting.
Not 4 years, 4 days.
4 days. I think you have to go with the authors, what they are saying. They said that they manage the patient initially in the ward. I think you must take their word on that. Okay, okay. There is no point of arguing on it. No, what they are saying is that the post-operative course must be hectic. Any other question? Handle such cases with a post-operative hectic period. I was wondering that how it can go 3rd day and 5th day discharge. Okay. I was wondering. The dissection was very wonderful, surgery was very wonderful.
Thank you, sir. Thank you, sir.
Thank you, dear, for your nice presentation.
Yes.
I recently came with the similar type of the patient, operated 1.5 months back. And what is the etiology of these cases? Have you gone through the literature?
So the most common pathophysiology that is said is about the loss of fat in between the aorta and the aortic and the mesenteric angle. That is what is said.
Because why I am asking this?
It becomes a vicious cycle. The nutrition goes on decreasing and the pad of fat decreases.
Oh, it's okay, but what I am asking basically is that this child presented 4 or 5 days back before coming to you. Am I right? But if etiology would have been since birth, then he would have presented before, right? Yes, so it is not that easy way to say that there is a decreased angle between the superior mesenteric artery versus the aorta. It is basically fibrosis. You have nicely see that there was a lot of adhesion at the point where the D4 is there. So these are the things which is more of supportive of the etiology rather than just simply saying because there is a less decreased angle of that. So your job was excellent, and we also did the same thing. So it's congratulations to you. Thank you.
The automatic angle was measured by on CT, sir. That was their conclusion that it is about 5 degrees only. And so and even I was not sure of the diagnosis when according to them, because patient had presented for the first episode, and usually SMA syndrome is usually progressive and a long history, but this patient was not giving any long history.
They are basically have a recurrent pain like a
Yeah, but this patient was not having any history. Okay. That was the most confusing part.
Wonderful. A wonderful presentation.
Thank you.
It seemed like possibly you may have edited a part of it when you dealt with the perforation in the fundus. Did you like freshen the edges? Because it looked like
it was a bit freshened. The thorough wash was given, freshened, and then closed.
And because of the location of the perforation, it seems that an endo-GIA could have done the job easily, isn't it? Stapler, fundus, because it's
it could have, sir, but
I mean, what you did is absolutely all right. Just hindsight.
Thank you, Dr.
Thank you. So I think this brings us to the end of the first session. Thank you all the presenters.
So this finishes our video session 1. I invite all the chairpersons and speakers for group photograph on the stage. So kindly come on the stage. Speakers, please come on the stage.
One more. Yes, switch off. Switch off. Thank you.
So let's start with the video session 2. I'd like to invite our chairpersons for this session. Dr. Avinash Yadav, sir, Associate Professor. Dr. Avinash Yadav, sir. Dr. Pranay, sir, Associate Professor, IMS BHU. Dr. Tanveer Roshan, sir, Additional Professor, RML PGI, Lucknow. Dr. Inzar Ahmed, sir. Dr. Vijay Kundal, sir, RML New Delhi.
वाईफाई चेक करने वाला 3361 ऑडियो आपकी चलेगी ठीक है यहाँ पर स्क्रीन शेयर एक मिनट में कर देता हूँ स्क्रीन आपको शेयर कर देता हूँ उसके बाद आप कुछ भी अब इसके बाद आप मिनिमाइज करके कुछ भी कर सकते हैं ये मॉनिटर
Dr. Kundan, chairperson. Announce.
Thank you, sir. Respected chairpersons, our first speaker is Dr. Anjan Dua, sir, who will be presenting on Achalasia cardia, experience and technical details, and also on thoracoscopic CDH repair using synthetic patch. Over to you, sir.
Thank you. A very good morning. Should I join or no? Okay. So there was a glitch. I think the video didn't load. Let me just go through the process. Oh my God, I have to use the pen drive now. Let me see. Okay. Okay. So thank you, Dr. Basant, the entire SGPGI team. A wonderful meeting. For a change, I sat through the entire course of the events yesterday. Didn't even miss a single talk. So this has been, we have been performing Achalasia cardia since 2016. Dr. Bhatnagar was there when I did the first one. First 2 or 3 odd cases we did hesitantly, and then we understood that yeah, it can be done with moderate amount of skill. One can modest skill, laparoscopic skills. One can do it, and minded it is a rare condition in especially in children where the incidence is such that we even in a center like AIMS we do get only 2 or 3 cases a year. So till now we have done 9 cases. Sorry, that's a mistake. 9 cases, and as low as 0.75. This child has had AAA syndrome. In fact, 2 cases out of these 9 had AAA syndrome, and all were primary cases. So by primary, I mean they were not dealt with any other endoscopic or any other or redo laparoscopy cases. So the following the Hellers, we managed them by Nissens. All of them except one where I did Thals, and the Nissens is a floppy Nissens. I had problem with one case. I'll deal with that later. And the video that I would show is, however, showing a Thals, Thals anti-reflux procedure. So we confirm our diagnosis, unlike the gold standard where it's mentioned that we must do a manometry. before we label a child as a case of achalasia. However, we have been doing only contrast study followed by an endoscopy to look how the sphincter, does it relax or not. So this is the layout that I prefer, and this is what has been the standard that is mentioned in literature, standing at the foot end with a monitor at the head end. We need two one of course for the camera, and this assistant can be spared off if we use what we call as a hammock suture. I'll show you how it's done. And these are the port positions, and sometimes we need two more, not the cranial most one. That can be, as I said, we can avoid that. However, the other one is a must, because that possibly that is required for traction of the G junction caudally. Without that, the dissection becomes a bit difficult. So the ports here I have used a retractor, fan retractor. The first step, of course, is to get into the space by taking down the gastrohepatic ligament, and then as that is done, we can see the right crus, that is the peritoneal covering of it, is removed. The crus is delineated in its entirety. Now here on the steps would differ if we do a Nissen's. So for that we have to create a retrocrural window, a very nice one, a generous one. Otherwise, and that's the left one also in view. So because here I did a Thal's procedure, that window was not made, a very wide window was not made. So this was, I thought, enough for us to mobilize the lower esophagus. And then of course the phreno-esophageal membrane is divided. That's the peritoneum being taken care of. And then we go ahead with the anterior dissection. So as we proceed, we confirm the position of the vagus anteriorly. That has to be preserved in all. So this is the phreno-esophageal ligament being divided. And that's the vagus, if you can appreciate, onto the right of the instrument, coursing. There it is. So once that is done, the dissection should fairly go. I mean, here we have taken the umbilical tape around to put traction on it, and then we can proceed with the mediastinal dissection, which delivers the lower esophageal sphincter, the area, the G junction caudally. This is important because we need to do a myotomy of at least 6 centimeters, 5 to 6 centimeters at least. And I use this, this is the neuro cotton that we call. It's very useful, doesn't fray, and super absorbent. Whenever there is a little bit of oozing or hemorrhage, that takes care of it. So once the mobilization is done, this has to be done, of course, if we do Nissen's. Even before I embarked on doing a Thal's, I thought I would do a Nissen's, but then looking at the floppy, looking at the repair that I did, I switched to Thal only for this case, this particular case. So as a rule I divide, so I divided, but I ended up with just a Thal's, so which would not require so much of dissection of the short gastrics. So once the cranial most part is reached, the short gastrics now divided, spleen freed, the fundus is also free, more or less, yeah. So then we do the myotomy part. So this starts with like what Ankur showed with lateral traction on either side of the myotomy site after scoring it, of course, with a monopolar. So once the space correct plane is reached, further dissection becomes easy. After that space is created, I use a neurocotton pledget again, and like we do for TEF repairs, I put it under the muscle, the hypertrophied muscle, and it creates the entire the length of it prepares it for the myotomy. The space gets well delineated. Once that is done, of course, traction is required for splitting. We can use monopolar, we can use harmonic. So that takes care of the using that happens intermittently. And then you can appreciate the space that has been created. So that's how the myotomy proceeds cranially. Suction also helps, even for dissection, for applying pressure there, and then at least after doing a 6 centimeters dissection, we go caudally. So I'm skipping this part. So myotomy almost done. That's the main course underlying. Free laterally also you can appreciate it's almost close to 180 degree has been freed. Mucosa is bulging nicely. So again, from the point where we left, we go down caudally. This part is the trickiest, as the plane may not be created as easily as done for the upper part, but yes, with traction and lateral traction, the fibers do get they do split up nicely, and bit of hemorrhage can then be controlled. Once the length is checked, I've skipped that part. We check the length that has been divided, and after confirming that myotomy is adequate, we check for leak by withdrawing the nasogastric tube. I didn't mention in the preoperative period after anesthesia is in that, we don't use a dilator. A wide bore nasogastric tube suffices. So that is withdrawn, and then we check for leak by putting in water and doing the leak test. So once that is done, the fundus which has been mobilized is stitched to the first to the left side, 1 or 2 onto the cranial most part, and the final stitches on the right side. The crus also had to be, the hiatus that is dissected, that needs to be also, the crural stitches are also put before embarking on the dorsal. So that completes the procedure. So this was the stitch I was talking of, and this picture shows how it is taken, but the site is not a proper one. As you can see, this stitch should be taken right here, just above the phrenoesophageal membrane. Only then it will be able to lift the left lobe of liver. And the last case that I did, we could get rid of the extra port that we had used for liver retraction. So this is the post-operative thing, not done routinely minded. The right one shows clearance, almost complete clearance as as compared to the pre-op. So this was done primarily because this child presented with recurrent symptoms after 3 months of the procedure. This happened in a case where senescence fundoplication was done, and that's why the contrast study was done, and that's why I showed. However, the exact reason why it happened as of now, I'm not quite sure why it happened, but endoscopy was done, and even in endoscopy, the rat didn't seem to be tight, and of course, dilatation was done, which took care of the dysphagia. Other than that, we had 2 perforations. The first case in the series where it was dealt by opening up and repairing it primarily, but the last one happened and we could repair it, of course, with a primary repair. There was also a case where vagal nerve got injured, and post-procedure dysphagia I've already mentioned. So this is just a quick one showing how this, as you can see here, as we were doing the splitting of the lower part of the, here you could, I think you can appreciate, this is the perforation. So that was taken care of with a stitch. So with the limited experience that I have, it can be of course said that and of course laparoscopic Hirschsprung myotomy currently is the gold standard for treatment. It has acceptable complications and satisfactory outcome. In my opinion, neurosurgical patty you can also try it once. It's quite handy and manages most of the hemostasis achieving and creating plane. It's quite handy. Thank you.
Thank you for the nice and crisp video presentation. One question regarding the upper, any landmark for upper dissection?
No, so I didn't, I mean, there's no landmark as such. You have to keep checking how long it is. Either you use the Maryland and take it out and with a scale. I use a silk suture, put it inside and measure it. And I mean, extracorporeally measure and check whether it is at least 5 centimeters I would like to have cranially, and about a centimeter or so, 2 centimeters max caudally. So that adds up to make it 6 to 7 centimeters.
Okay. Regarding the perforation, you repaired the perforation and continued with the rest of the dissection?
Yeah, rest of it was done as we do. No additional covering. I think Avinash might have shown one video where omental patch was put, but I didn't put it. I think it's not needed. It's mentioned in the literature. It can be dealt with as we do it. Just primary repair and go ahead with the rest of the procedure.
So one more question, sir.
Yeah.
In the cases where you had mucosal perforation, was there any history of
no
repeated dilatations?
Yeah, that's what I said. In my cases, all the patients have landed up without any prior intervention. Prior endoscopy is done, but no dilatation. Yeah.
Because I'll be presenting a case where I will show you something which I thought might be the context.
Yeah, of course.
Any question from the audience?
Yeah. Yeah. Flop.
I saw you were using monopolar pottery at the very beginning part of it.
Yeah.
So that is really dangerous.
Yeah.
Because monopolar pottery can get transmitted. So either you just manually break the fibers, or you make a plane and use harmonic. Harmonic will not get transmitted. You have to put the cold shear below, the hot shear up.
Yeah.
So maybe you can avoid it.
I mean, I was doing with harmonic as you pointed out. I mean, only that part. Yeah, it's a good. I mean, yeah, I used pottery only when the mucosa had fallen down. If you would see, that was a wide space. Yeah, the mucosa had already fallen, and there was quite about, I would say, 2 to 3 centimeters gap between that portion. Otherwise, I use harmonic to do it and traction, as you said.
Thank you. We can move to the next presentation.
I think I'll do it because there is a lot
please
of,
continue.
That's. नहीं दो I'll continue. Okay, so when Ankur told me this is a, I mean, the theme was gastro. He suggested you can present even a thoracoscopic procedure. So this was done. I mean, this is a CDH where we used patch. We routinely use it, not routinely as such, but using patch is nothing new. Technically, it is demanding just because there is a lot of intracorporeal suturing. So I thought I'll just demonstrate it, something which we don't do it routinely. So this was a full-term boy, 2.3 kgs, presented on 10th day of life with increasing respiratory distress, starting 5th day of life. Initially, the child didn't have any issue, and even there was no antenatal detection. So this is the X-ray. You can appreciate the CDH on the left side, and hemodynamically the child was absolutely stable. My preference is to do it open, and this is the first time which I did CDH thoracoscopically, primarily because the child was absolutely normal hemodynamically, and in fact this was done in the middle of night in the emergency OT. The child was absolutely stable, so we thought let's give it a try. Sorry. So here with 5 mm port, we put the other ports under vision, and with scapnothorax, as you can see, the bowel, which was occupying almost the entire thorax, has now receded. Now the terminal part and the stomach, which is appearing distended, is getting reduced. Spleen is the last part to go into the abdominal cavity. It's a little tricky here. We have to avoid holding the splenic tissue. We either catch the pedicle or on the lateral aspect. So ultimately it reduced, and to our surprise, when we assessed the defect, it was quite a large. So at that point I thought what to do, but I thought let me just do a little bit more of dissection, and as we do in open procedure also, here even the liver is adamant, a bit of liver has also now appeared in the. Okay, so this is the posterior part of the muscular rim where we remove the peritoneum to unfurl the muscular rim. So once that was done, this is the GE area, freeing up because I thought that would otherwise interfere with the sutures. So this was little risky, I would say, using cautery here. So once that was done, we started off with the suturing part. Normally, I would have taken a central stitch first to keep the bowel loops and the other contents not to appear into the field. But here, because the defect was quite a bit, I will show the defect once this part is over. So this is the defect, and there was no way that I could have taken a stitch at the center first. That would have freed my left hand. But anyway, we started at the angle. This is the medial most part. This is a 2-0 silk. So after putting 2 stitches, I realized that it's not happening. I mean, of course, the stitches have been laid. Further stitching would have, in fact, I took another stitch after this, and then the 4th one, there was cut through. So that was the time when I thought we would require something to augment, I mean, a patch to cover it up. So even after deciding on that, I took two pericostal, the stitches with the ribs just to hitch these lateral aspects. This was done. This, the third one. So this is the stitch which is going across the rib and coming out onto the skin. So even then, this narrowed up, I mean, closed the defect further, but complete occlusion was not possible. So this is the Gore-Tex patch which was pre-measured and designed. So these are the stitches that, this is one stitch on the right onto the posterior aspect. So with multiple silk sutures, this was fixed to the muscular rim as well as to the ribs to keep it in place. The muscular rim was taken primarily first because to get fuse to see the structures which are behind so that bowel doesn't come forwards. Otherwise, the stitches might go through the bowel. And after doing the muscular part, the stitches were taken on the ribs, across the ribs. I mean, around the ribs. So that's how it appeared at the completion of the procedure and the chest drain. So uneventful recovery, extubated within 24 hours. And this is how the X-ray in the postoperative period, and full feeds on day 4th or 5th. Thank you.
Thank you. Any experience regarding there are any vascular communications with the spleen?
No, so echo was done in this case. There was no cardia. That's why I said it was asking to get, I mean, asking for thoracoscopic repair. So 10th day, no hemodynamic instability, echo was absolutely normal, and just maintaining by nasal oxygen.
Sir, Anjan sir. Sir, what is the how much is the follow-up period now for this patient?
As I said, this is the case when uncle called me up. I was there in the OT. So today is 5th day and established full feed. Just now I called up before entering.
Okay.
But the after removing the chest drain, we have done an X-ray and it shows almost near complete expansion of the lung, and the diaphragm remains intact as of now. I mean, I know follow-up period is important here because we have used the Gore-Tex patch, so we'll look for recurrence. In fact, there could be even anomalies. I mean, skeletal abnormalities could also. We have to look for that. We have to keep a watch.
I think we can move on. We'll just take 1 or 2 questions in every, because we have to go to the free paper session, which is our residents, all residents want to present the free papers. So we'll just wrap up this video. Like the
last one,
last video, just
quickly,
quickly, and then thank you very much. Yeah.
Okay, the third one is a thymectomy that has been done for a juvenile myasthenia gravis. Okay, so I'm skipping although here it's important for us to understand the indications, the surgical anatomy as such. I'll just go through it. Clinical profile briefly, this was a 13 years female with drug-resistant myasthenia gravis, was on pyridostigmine and azathioprine, was non-ambulatory at the time of presentation to us, and she was completely bedridden and could only walk with support. So after an MRI which was done showed normal, more or less normal. There was no thymoma, but yes, the thymus was enlarged with its normal maintained contour. But if you go through the indications, this case fitted into a case which would require thymectomy. So we proceeded with that, and this is the diagram showing the anatomy. I'll not go into the details. Just to briefly, the steps consists of dissection of the lower part, the right and lower horns, freeing it up from the pericardial membrane, and of course taking the two horns, the right and the left cranially. What is important for us in thoracoscopy is to stay always anterior to the phrenic nerve. That has to be taken care of. So this was the port position with slight 30 degrees tilt. Here, as we entered, this was this case needed a bronchial blocker for the left side for unilateral, and this is the phrenic nerve. So this has to be visualized, and our dissection has to stay above it, lest we injure it. So once that is done, we free the membrane, the mediastinal pleura cranially, starting cranially and going inferiorly. The entire length has to be freed up. Here you can see the cranial most part has been reached. The limit is the innominate vein. That's the cranial most extent of dissection. Here we are going inferiorly, and as we reach the pad of fat around the caudal end, that would be the lower extent of dissection. So once that is done, the thymus is then lifted off the pericardial sac. That is the lower horn being lifted off, and we do repeat this process till the entire thymus, or most of it, is lifted off from the pericardial sac. So this is the lowest of the left side. Then we proceed to the right aspect. So once that is done, we have to now shift our focus to the horns, the cranial most part, where it's a bit tricky. There are no absolute planes to actually go through it because it's a fibro-fatty tissue which surrounds the capsule, and capsule is quite thin. So we have to handle the tissue gently, and the aim is to excise it en bloc. So control traction with harmonic, we try to dissect the pleura away, and that's the phrenic nerve again in the field. We stay again anterior to it. Once that is done, we enter the space which is just under the innominate vein. So in children, what is our understanding of thymectomy comes from the literature which is available in adults, which mentions that the vein has to be identified, skeletonized, clipped, ligated, and divided. But here in children, it's not possible. So here I took help from, I would acknowledge support that I received from our adult surgeon, Dr. Mohit. He does a lot of these procedures. So I asked him, even before embarking on this surgery, I reviewed quite a few unedited videos done by him. So that helped me a lot because this territory was new to me. And this is the phrenic nerve has been saved, and we have gone under the vein now. I mean, just below it, we are about to take down the horn. Here, which was taken with just the harmonic. Now the entire fibro-fatty tissue is onto my left, and with gentle traction, I'll just show that the vein just showing up, and now that it is visible on either side, I took it down with harmonic. I'll just show you the innominate vein will be in the field. Here you can see it. That's the horn, the last bit of the attachment. Then after taking down the left one, dissection proceeds to the right, where the brachiocephalic gradually, as it merges with the opposite brachiocephalic, becomes the SB, the superior vena cava. But before becoming superior vena cava, we have to take down the right horn also. So here you can see the right horn being dissected. So that has been now done. I just kept it anyway. So this is the last bit of the tissue. So that is how it is done. And then we, so this is the last bit of the right horn being taken care of. So that's the SBC in the field behind. And this is the anterior mediastinal pleura. So now the field is absolutely, I mean, the SBC is completely freed up, skeletonized almost. The last bit of tissue, sorry, this is the innominate vein. The SBC is even lower. This is the horn actually. This is the left horn, sorry, right horn. This tissue is being freed up now. So once that is done, this exactly is the, this point I would say is the last bit of tissue of the right horn. So once that is done, the vein that is seen below it could be called as the SBC, because we will not skeletonize or visualize the entry point of the opposite vein. So that is done completely, bit of more attachments being free. So once that is done, the difficult part is almost done, and it is a matter of time that we free up the rest of the thymus and it is taken out. But yes, we have to also look for ectopic sites, any pad of fat, any bunch of tissue which is fibroadipose around a pericardial sac have to be taken biopsy. Otherwise, it is known. I mean, this is the area, the left side is known to, I mean, 40 to 80% of the ectopics would be on the left side. This is why people approach it from the left. But there are indications for right-sided approach also, and there are reasons to also go from the right side. I'm not discussing it here right now. So that is the tissue, the last bit of tissue being divided, and that's how the thymus is completely now freed up, ready to be removed. So I'm stopping here. So even now she is on drugs, but she is mobile, and the the immunomodulator has been stopped at least, and she's on pyridostigmine and moving. I think there is a bit of tissue in the cervical area. Probably that is the area which we have to look for now, and may require further intervention if she deteriorates over time. But as of now, we are keeping a watch.
Thank you for this adrenaline surge video.
Doctor.
Yeah, so as I told, I had to keep Dr. Mohit. He was very kind enough to come to OT and sit, just sitting, coming and without watching is the most difficult part, I would say. But he was there throughout, and he didn't even at one point I told him to please come and dissect that part which was looking dangerous. Dr.
Anjan, I must compliment for doing these surgeries. We all have a very limited, experience of.
Yeah, of course,
as literature says, the right-sided approach is, mostly done. I think
there are
contralateral side, left side,
right versus left.
Yeah.
Because as of now, see, here there was no thymoma, and there was no preferential tilting of the organ onto the right or left, as the MRI showed a symmetrical disposition. And because here I would say the decision was Dr. Mohit who said that my experience is of course of this case, but yes, I have to see how the anatomy is from the right and decide finally which is better. So as of now, my preference would be again to go through left. Once I gain bit of more experience, I would try the right side.
That's great. Any advice on pre-operative preparation?
So preparation is, there's a hell lot of preparation starting from the, of course, the most of it is already done by your colleagues, pediatric colleagues who would decide whom to send, whom not to send. They would never send to us because in pediatric age group, hardly anyone would require surgical intervention. This is one of the rare cases, I would say. One case is lined up, dated for next month. But other than that, even they told me कि हमारे को जरूरत नहीं पड़ता है, and they follow up till 18. In our institute, they manage till 18. Till 18 they say कि नहीं जरूरत पड़ता है. So that is how it is. But in adults, yes, it is much more. I would say the indications would be even thymoma. There would be some lesions which would definitely require surgical
Excision. Yeah. Thank you so much. That's a great presentation. We can now move on to next session.
Thank you so much, sir, for all the excellent talks. I would like to call upon Dr. Avinash Jadhav, sir. Sir will be delivering 2 talks. That is, one, omental patch repair for esophageal mucosal perforation in laparoscopic achalasia cardia. And the second talk will be on laparoscopic vaginal reconstruction in a case of 14-year-old girl with cervico-vaginal agenesis.
Avinash, can I just request you to present one of them?
Yeah, I'll just.
Yeah,
I'll present one only.
Or within 5 to 6 minutes, we can just see the critical step of each. Because I think we should give chance to the residents to present their papers here. Thank you.
I'll straight away go to the video with the point which I want to emphasize here. Yeah, please. Much of the related talk is being given by Dr. Amjan sir already. And what happens is, as we surgeons prefer to have favorite instruments or a preferable instrument whenever we are dissecting. It can be a mixture, it can be a quadric forceps, a specialized quadric forceps, a special tip. And that bias can be sometimes dangerous. This is what happened in this case. That is what we think is the cause of the complication. This was a usual achalasia cardia in a 15-year-old patient who was on repeated dilatations, endoscopic dilatation in a quest to avoid surgery. So the patient was presented to us late with a dilated esophagus, foul smelling, vomitus on all those features. And we had to go ahead with the, after investigation, we decided to do a cardiomyotomy with a fundoplication. Here the surgeon's preferred instrument or a favorite instrument is a cautery hook. So all the division of the muscle fibers is being done with cautery. And this is what led to the catastrophe. That is what we think. Muscle fibers were divided with cautery and by hooking it up quite high. So whenever we hook a tissue, there is a fair chance of the underlying tissue to get dented with it. And when we use cautery in such a narrow space, whatever we might have an experience that the conducted current is not that much, but in such narrow space and in such critical areas, it can still affect the outcome. So this is what every place the cautery was being used to divide the muscles, even for when a blunt dissection was attempted. And so the myotomy progressed till we found a suitable dilated esophagus. And at the time of splitting of the fibers, there was a mucosal perforation in the esophagus. And there were a lot of content. See, here we can see the perforation with the NG tube seen in it. There was a lot of collection in it. The dilated esophagus was full, even though after giving washes preoperatively. So this complication occurred. We repaired the mucosa first, and then with interrupted sutures. After thorough suctioning, we repaired the mucosa, and as we have a tendency to pull omentum, we did a omental patch repair. A live omental patch was used as a second layer. So this is the repair of the mucosa, and this is the omental patch that has been omental flap that has been created, and it was sutured over the mucosal repair. This is what I wanted to demonstrate. Thank you.
Yeah, great.
I'll go to the. Someone come and help me. Okay. Second session.
Other session, video 2.
This was a patient who was a 15-year-old female child who had come to us. A 14-year-old female child who had come to us with pain in abdomen and lump in abdomen, and had not menarche yet, but she used to have cyclical pain, and she had gone and she was being treated by a adult gynecologist before she was referred to us. The gynecologist had attempted dilatation of the vagina over a guide wire, thinking it to be a transverse septum or something, and in that procedure there was injury to the rectum, and the rectum was sutured with Vicryl 20, and the patient was referred to the adult gynecologist in our institute, and adult gynecologist then referred the patient to us in view of the rectal injury and probable rectovaginal fistula in the future. So this is the background of the story. Then the patient was evaluated, and there was on an MRI there was a cervicovaginal agenesis. We managed the rectal injury conservatively for 2 months, for around 8 weeks, and then repeated the MRI, and there was no fistula. The patient was in between us and the gynecologist. The earlier adult gynecologist wanted to do the case, but then they referred the patient to us. So we decided to do a bowel replacement for the vagina. This is the dilated uterus with the dilated and tortuous fallopian tubes were seen. We marked the sigmoid colon. The length of the sigmoid defect was measured with a marked umbilical tape. This is the division of the colon, and the colon was mobilized, and it was brought into the perineum first. The perineal sutures were, the vaginal sutures, vaginal colon anastomosis was done. The anastomosis was completed. Then elliptical incision with some tissue was removed from the uterus up to the cervix, the atretic cervix area, trying to get as dependent as possible. There was around 400 ml of collected blood in the uterus, which was sucked out. And then a utero-anastomosis was done. The posterior was done using a barb suture. And this is the posterior continuation of the posterior layer. The uterus was very thick. You could see the needle being getting. The anterior layer was done with a Vicryl 30 in an intermittent fashion. This is the completion of the uterocolic anastomosis. And then a sigmoid colon anastomosis was completed with interrupted sutures with Vicryl and a barbed suture on the one there. And this is the completion of the surgery. On post-op course, we did a vaginoscopy after 3 weeks. The new vagina is patent, and both the anastomosis were normal. Patient was having menstrual cycles. So laparoscopic vaginal reconstruction can be done with precise dissection in the pelvic cavity. Intestine is used, and it is, although it is technically demanding, but it is still possible. Thank you so much.
Yes. So I have a lot of experience of this bowel vaginoplasty, and I really recently had 2 patients where we had missed out on the rudimentary uterus. And now they present with the metametra, and I did open surgery and did anastomosis. It did work for about 2 months, but then eventually a very wide anastomosis that closed down. So very long-term follow-up are very much important for such patients where you've done. And secondly, because they do not have a functional cervix there, so it's something like cervical incompetence, or when they get married and all that, the pregnancy is a major issue.
So earlier our plan was to do a hysterectomy if the patient agrees and give a bowel vaginoplasty, or if there is a rudimentary if vagina is left behind, we can go and all those things. The patient was already counseled by 2 gynecologists, and her family was really very adamant that they don't want to remove the uterus.
No, that's
so we had to go ahead with whatever complication, and we had explained everything to the patient, but that's how it is.
Of course, it's their choice, and if I was involved, I'll also like to retain the uterus. No, but what I'm trying to say is that the 2 issues which are later, one is this anastomosis done. I mean, of course, I've got a small experience, but a very large experience of doing vaginoplasty, but very small experience of actually missing out the uterus and then trying to do anastomosis of the what bowel vaginoplasty I've created many years back to the uterus that is found now at puberty. So the anastomosis, whatever wide you may do, I don't know, I read a lot on this now.
So that's why I incised the elliptical part of the uterine wall, so that it stays.
We all do that, otherwise anastomosis anyway, it's not feasible, not easy. But take care of that, and then about the pregnancy, and just in case the pregnancy actually occurs, of course, they need to have a cesarean. They should be very clearly told that.
Yes, thank you.
Thank you for your kind input. Dr. Avinash, excellent presentation. And I think laparoscopy has, made this possible to anastomose this bowel to the uterus. My only query is how we can decide where exactly we need to anastomose in the uterus? So that becomes exactly. So that's the question.
So that's not described anyway as a fixed landmark, but we try to go as distal to the rudimentary cervix, so that nothing collects in that pouch.
The patient would be lucky. The patient has got some amount of blind vagina and cervix above. Then it is easy. You open that vagina and then anastomose vagina to vagina. Your bowel vagina to that vagina. But if that is not there, yes, there are no landmarks mentioned in the literature really where to go and ask.
Sure. I think we need to conclude this session. We need to conclude this session. Thanks to all the speakers. Very great presentations. Thank you.
I once again thank all the speakers and chairpersons. We'll now assemble for a group photo. All the speakers and chairpersons, please.
Light off. Light. Please cut off.
you, sirs. Moving on to the next session, we have a long oral paper presentation that will be for 5 + 2 minutes. So for which I would like to request the chairpersons to kindly grace the dais. I request Dr. Intizar Ahmed sir, Additional Professor, AIIMS Rishikesh, Dr. Pramod Sharma sir, Additional Professor and Head, AIIMS Bhopal, Dr. Sandeep Rahul sir, Associate Professor, IGIMS Patna, to kindly grace the dais. इसमें क्यों नहीं आ रहा है? I also request Naveen Chandra sir to kindly grace the dais. Naveen Chandra sir is a senior specialist pediatric surgeon at Command Hospital, Kolkata. Thank you, sirs. Okay, our first speaker for the session is Dr. Rahul Dios Sharma from Lilavati Hospital and Research Center, Mumbai. He will be presenting on risk prediction scoring system to predict the post-surgical outcomes of biliary atresia.
So this is a prize video session. We have first prize and second prize. It's 5 + 2. And I will please request the chairpersons to stay, restrict the discussion to please 2 minutes and maybe 1 or 2 questions, please. Thank you.
There's been a slight change. Chairpersons, actually the paper will be on outcome of biliary atresia after Kasai portoenterostomy from Lilavati Hospital and Research Center, Mumbai. Over to you, sir.
Thank you all for giving me the opportunity to present here in presence of esteemed teachers and all the dignitaries. I, Dr. Rahul Dev Sharma, would like to present this presentation and want to thank Dr. Rectal to giving me this opportunity to present his experience on his behalf. So, Kasai portoenterostomy, I've titled it as not less than a milagro. So, you must be thinking what this milagro is. So, milagro is a Spanish word, accounts for a miracle. And why I'm saying this Kasai portoenterostomy to be a miracle? Because just around 6 decades ago, the biliary atresia was a fatal disease. At that time, almost all the patients died within 1.5 years of age. But after this Kasai portoenterostomy, as we have seen yesterday also, we have very good results, and the fatality of patients after Kasai portoenterostomy is coming to 0 almost if it's been treated at certain point of time. So Kasai portoenterostomy is currently the surgical treatment of choice to restore bile flow and relieve jaundice in children with biliary atresia. The ultimate success of Kasai depends on several factors, which can include patient's age at the time of surgery, presence of cirrhosis, surgeon's experience while performing Kasai portoenterostomy, occurrence of postoperative cholangitis, and some unknown genetic factors. So here in our study that we did, it was a retrospective study. 121 patients were included who underwent Kasai portoenterostomy, and we have protocolized a study with a clinical examination, stool color, liver function test, torch serology, and Hydatid scan. At the time of data collection, the data was collected for almost 121 infants, but at the end of 1 year follow-up, we have records of 89
patients that were available with us. At presentation, all the patients had pale color stools and dark color urine, while 85 of the patients had splenomegaly and 17 patients were having clinical ascites. This is one of the most important slide I would like to say. So these are the days at the presentation. As you can see, if presentation at the time of Kasai was less than 60 days, the alive number was 7 out of 11. That accounts for 63.6%, and the jaundice free was almost 55%. That is number 6. While if age was more than 120 days, the alive number of patients drastically dropped down to 36%, and out of those also the jaundice free is only 3 patients, that is 15%. This is the biochemical profile of all our patients who underwent Kasai enterostomy. So we have marked 3 things here. One is the total, one is children alive at 1 year and jaundice free at 1 year. And if we had looked the total bilirubin and any other test, we found that either it is a total bilirubin in all the patients or the patients who alive at 1 year or the patients who jaundice free at 1 year, there was not significant difference in the investigations report that we had. We were thinking we have done so many patients and still we are not finding any of the difference. So is there anything that we are missing? So we came to know about some parameters that I'll discuss in my next presentation. So all the patients we had 121, 78 were tested for cytomegalovirus, in which almost 50%, that is 39 were positive, and all were treated with gemcitabine. Regarding the congenital anomalies in our series has 27.8% of the patients who had congenital anomalies. More than one anomaly was there in around 7.5.
Just 1 minute left.
Okay. More than one anomaly was there in 7.5% patient, while the polysplenia and umbilical hernia was the most common anomaly. The results we have taken was the jaundice clearance at 3 months post Kasai enterostomy, and out of the 89 patients we had, 42 were having jaundice clearance, accounting for 47.2%. So we conclude that jaundice clearance rate at 3 months post Kasai was significantly higher in patients who are alive to those who expired. To conclude, I would like to say that post-operative bilirubin value at 3 months at predictive value with those with jaundice clearance at 3 months faring better than the rest. And jaundice clearance at 3 months post-op is a good early indicator for long-term success of Kasai enterostomy. Thank you.
The house is open for questions, please. Thank you, Dr. Al. I think there are no questions.
Thanks.
Okay, and next paper will again be by Dr. Rahul Dio Sharma. It will be on risk prediction scoring system to predict the post-surgical outcomes of biliary atresia.
So as I am continuing only, I told in my previous presentation that biochemical profiles that we did in all our patients leads to nothing. So we thought what we can do or what has to be there to see in patients who are undergoing Kasai enterostomy or just after Kasai enterostomy that we can deal with. So we have published this paper that I am going to present now. It was to assess the outcomes of LFTs and histopathology on outcome of biliary atresia post Kasai enterostomy. So it was also a retrospective study for a duration of 18 years, and all operated patients that we have taken from a single center by a single surgeon. LFTs done. LFTs in same institute and histopathology reported by the same pathologist. Out of the 149 cases, 20 cases included in the study which met the above criteria. Age at the operation was considered the window of opportunity for these patients, while it is no longer valid as our own recent article where we have operated 120 children that I mentioned in my previous presentation only. We have children who were operated below 60 days of life and they fared better, but some had died also. But there were children who were operated at more than 120 days of life, and some were alive while some was dead. So final outcome we have taken here is alive with jaundice or jaundice free and disease. Now what we have done in this paper, we have checked the liver function test and histopathology, and we have taken some of the indicators that we can include. We have reviewed some journals and some newer indicators and came to know about these tests that we have checked. One was the percentage of direct bilirubin, AST to ALT ratio, APRI, GGT to AST, GGT to ALT ratio, bile ductal size and grade of fibrosis. So whatever percentage of direct bilirubin, it is probably more indicative of obstructive liver damage than just total bilirubin level. It removes the age of a patient as confounding factor, and we have divided groups of 10 starting from 61 to 70% till 91 to 100%. While for AST to ALT ratio, there is a paper by B.R. Thapa and Anuj Walia. They said this ratio is indicated of chronic liver disease, and ratio of more than 2 is specific for cirrhosis of liver. While APRI, this was published by Andrew Grieve and Mark Davenport, is suggestive in chronic liver disease to evaluate the grade of fibrosis. There is another GGT to AST and GGT to ALT ratio. This ratio is a known indicator for biliary atresia, which have been stressed a lot in the previous studies by Kuo Sun Tang. Another is a Ishak staging that we have taken. This is the staging for grade of fibrosis. The used for stage 0 to 6, where 0 is no fibrosis and 6 is suggestive of cirrhosis, probable or definite. While the size of ductus that we have graded, the bile ductal size of more than 250 micron is considered as the size associated with better survival post-Kasai portoenterostomy, while the other size we have divided is less than 100, 100 to 250, and more than 250 micron that we have assessed on our histopathology reports. The shocking results that we got here was out of 26 patients, 16 were alive and jaundice free, that accounts for 62%, while 10 were deceased. And then we have done a complex statistical analysis along with some statisticians and with our research teams. We have plotted logistic regressions, ROC evaluation curves, and factor analysis, and found that AST to ALT ratio, APRI index, and grades of fibrosis were statistically significant.
1 minute left.
So these are the graph we have plotted: grade of fibrosis, AST to ALT ratio, APRI, and ROC evaluation curve. So, we have done Kaiser-Meyer-Olkin measures for the sampling adequacy, and after this test, we came to know the sample size we have taken was adequate for our study. So, after this all statistical analysis, we came to know that APRI value of 1.8 has a true positive rate of 90% and false positive rate of 30%, while the SGAT to SGPT value of 2.2 has a true positive rate of 80% and grade of fibrosis of more than 4 has a true positive rate of 90%. So we said that AST to ALT ratio less than 2.2, APRI less than 1.8, and grade of fibrosis less than 4, irrespective of age at surgery, accounts for successful Kasai procedure in 96.2% of the cases. So we made a risk prediction scoring system out of this study, which said that if we have a cumulative score ranging from 3 to 7, risk is going to be mild and patients are going to be survive after Kasai. If it is 8 to 16, risk is going to be moderate, and 17 to 20, risk is going to be severe. This risk scoring system is applied to all the children presenting with biliary atresia, and based on the scores that we have inferred, 3 to 7 is good prognosis post-Kasai, 8 to 16 is equivocal prognosis post-Kasai, and the 17 to 20 is poor prognosis post-Kasai. This is a paper that we have published in JIPS for the same. And as Sanjay Rao sir yesterday told, whenever we are doing a Kasai portoenterostomy, we have to tell patients about liver transplantation also, and we have to prepare that patient for liver transplantation. Here, for those referrals are this prediction scoring system that we have made will be very useful, because if there are any patients who are coming to equivocal to severe in scoring system, can be referred for the liver transplantation as early as possible, and they can undergo liver transplantation. Thank you.
Thank you, Dr. Rahul. Yes, Dr. Anjati.
Nice presentation, Rahul.
Thank you, sir.
One query I had regarding the second paper.
Yeah.
You in the material section, you have mentioned that we considered 3 outcomes. One was alive, one deceased, and alive with jaundice. But while analysis, when you showed the results, you had only 2 factors considered: alive or deceased.
No, sir. The alive patients that we have taken, we have marked that alive and jaundice free. Some of the patients.
No, but yeah, I understand that. But when you mentioned that, you have grouped them into 3 groups, as I understand. Go to the previous one.
Sir, that was in the previous paper.
No, in this paper.
Okay.
Okay, it's okay. It's okay.
Dr. Sarin.
I just have one suggestion, that somewhere please incorporate presence or absence of CMV also in this, because that seems to be altering the clinical course of the disease in a big way.
So CMV we have included in our previous study for all the patients who were having CMV positive. We have given the treatment with the Zencyclovir, and for this study also we have taken that into consideration. But all patients were not coming into a criteria, fitting into a criteria, and when we have tested for the significance on a statistic basis, that are not coming into criteria. So that's why we haven't put it.
The only issue which I want to tell you is that, as I said yesterday also, the ones which do not have CMV, they usually will not fare well if they are treated beyond, now they say 30, 45 days, 60 days, whatever. But the ones which are CMV, the presentation is late, and they probably can be still taken up and have good prognosis.
Yes, sir. Yes,
at the age of 90 and whatever days.
Yes, sir. Next time we'll take that into account also, sir. We'll add whether that CMV was present in those patients also. Thank you, sir.
Make sure that more specialized.
Okay, sir. Okay, sir. Okay. Okay, sir. We'll try to incorporate that also. Thank you, sir.
Thank you, Dr. Rao.
All right. Thank you so much, Dr. Rahul. Now I would like to call upon Dr. Rahul Kumar Rai. Presenting paper on juvenile polyposis coli is a rare cause of lower GI bleed from KGMU, Lucknow.
Juvenile polyposis coli.
Next.
Good afternoon, sir. I am presenting a case of juvenile polyposis coli. We have such 4 patients in series. I am presenting the one 5-year-old male presented with chief complaint of bleeding per rectum after defecation since 2 years on and off. And according to the patient mother, child was well 2 years back. Then he passes the fresh blood after every defecation. Stool was not hard. There is no history of any constipation. Child passes stool 2 to 3 times in a day. Passage of the blood was regular and not associated with any type of the pain. Otherwise, patient was active, playful, and growing well. Currently, patient's symptoms were worsened, and he came to KGMU for the treatment. History of present illness: there is no history of diarrhea, any food allergy. There is no alteration of stool color, no weight loss, fever, hematemesis, or abnormal pigmentation over skin and mucosal membrane. There is a patient is a second child of non-consecutive parents. There is no such complaint in family. On general examination, patient is well conscious oriented.
Pulse rate was 92 beats per minute. Blood pressure was within normal limit. There is a pallor present, cyanosis, jaundice, and edema absent at the time of examination. For rectal examination, multiple pedunculated polyp felt on the distal rectal examination. In view of above finding, we plan for colonoscopy and biopsy. This is a picture of colonoscopy. Multiple pedunculated polyps are seen in colon, and the biopsy suggestive of juvenile polyp with no sign of any atypia or malignancy. This is the multiple polyps seen in the colon. In the view of histopathology report, we want to rule out any other polyp in upper bowel. So we go for the upper GI endoscopy. Upper GI endoscopy is within normal limit. This is the report of upper GI endoscopy, normal up to D2. And initially, patient was managed conservatively with iron and B complex with stool softener, but symptoms were worsened and patient need repeated blood transfusion. So we planned for the total colectomy with ileal J pouch, with ileal anastomosis, with ileostomy cover. And we start the laparotomy and mobilization of colon was performed. This is a mobilized colon. And from this is the dentate line, we cut here and some mucosal tunnel was created. This is upper segment, this is a lower bowel. And after removing all the colon, we created the J pouch, 10 centimeter each limb was created. And with the use of linear stapler, we created the J pouch. This is the gross specimen we resected from the IC junction up to the rectum. And after cutting, there is a multiple polyp present up to the this specimen polyp present up to the transverse colon, but we cut here. Post-operatively, patient is doing well, accepting orally, ileostomy functional, and patient was this is a photograph of the patient post-op day 6 when we planned for the discharge. And thank you. Little bit discussion. This is a polyposis coli for the multiple, which condition for the multiple polyp in the large intestine and used synonymally with familial polyposis. This is the autosomal dominant with incomplete penetrance. Individual with JPS are increased risk of malignancy of colorectal and gastric cancer.
1 minute left.
Okay, sir. JPS is due to the germline mutation of SMAD4 or the bone morphogenic BMPR1 gene, and the clinical manifestation, juvenile polyposis in adult, most probably they are symptomatic by age of 20 years. Overall, 90% of the patient present with bleeding and anemia due to the gastrointestinal polyp. Rectal bleeding is the most common presentation. Other presentation are abdominal pain due to the intussusception, or diarrhea due to the protein using enteropathy, rectal polyp. Sometimes they present with the epistaxis and other cardiac involvement due to the other extraintestinal involvement, hemorrhagic telangiectasia, hereditary, and they are increased risk of gastrointestinal cancer. There is a 17 to 22% by age of 35% and 68% by age of 60 years. They are prone for the malignancy. That's why we need resection of these polyp to reduce the malignancy, and resection of colon or diagnosis when we suspect when there is a more than 5 juvenile polyp in the gastrointestinal tract or multiple polyp or patient with a family history with any number of polyp, we suspect the JPS. Differential diagnosis में Peutz-Jeghers and nevoid basal cell carcinoma syndrome and hematoma tumor syndrome. Screening we done, and what are our approach in KGMU for patient with a JPS? We cardiovascular examination with complete blood picture and iron deficiency anemia. We go for colonoscopy, esophageal gastroduodenoscopy, and repeated annually if polyp are demonstrated, and additional evaluation of bowel pattern. Thank you.
Thank you, Dr. Rai. Any question? Yes.
I am getting a little confused I thought that juvenile polyp is something which is benign, and the
Yes,
one
sir.
which has this malignant potential is the familial adenomatoid polyps, not juvenile. Adenomatoid polyps.
So there is a increased chances of malignancy. This, if the patient present with juvenile polyposis, there is increased chances of colorectal cancer. These itself is a benign condition.
But that is adenomatoid polyp, no? Juvenile is a benign condition.
Yes, sir. Juvenile is a
And only polypectomy is usually.
Sir, polypectomy is needed, but yes, sir.
Total colectomy, and that too a non-affected area of the colon.
Sir, initially patient was managed with polypectomy and conservative approach for the 2 years. But the conditions are worsened day by day and patient need repeated blood transfusion. That's why we go for the total colectomy.
But yes,
there are definite indications for colectomy in juvenile polyposis
as well. Okay.
Yeah, and that is primarily loss of albumin and anemia. If they compare it to
Right, but do they have malignant potential also? That's what he has referred to.
it's not because of malignant potential, but because of nutritional problem.
Okay.
They frequently.
So I think we reviewed this with our Peds gastro team. So if juvenile polyps are less than 5, then it doesn't become polyposis.
Yes, sir.
So there, removing the polyp itself is enough. But if it is polyposis and it falls into the JPS syndrome, juvenile polyposis syndrome, then it has a small malignant potential. And as sir said, if it is associated with hypoalbuminemia and anemia, total colectomy and IUNL, J pouch or state is recommended.
And in fact, for children, J pouch is not recommended. The IUNL they have a troublesome 1 year. But by the end of 1 year, they settle down to smooth frequency of 500 days, which is manageable. J pouch children can give rise to more problems.
सर जेनेटिक एनालिसिस सारे केसेस में करना चाहिए ना ऐसे जो पढ़ते हैं पटनागर सर जेनेटिक एनालिसिस का क्या आप लोग क्या रिकमेंड करते हैं ऐसे जगह मल्टीपल पॉलिप हैं तो
So if it is adenomatoid, they confirm it by doing.
Yeah, that's what. Even in JPS, again the same thing. If it's polyposis syndrome, then you have to do the genetic analysis. So for polyposis, more than 5 polyps throughout the colon.
Yeah, that's an interesting discussion, but I think we have to move to the next question. Thank you, Dr.
Thank you, Dr. Rahul. Now I would like to call upon Dr. Sunita Singh ma'am from AIMS Raebareli. Ma'am will be presenting on right-sided Morgagni hernia and right eventration of diaphragm, 2 cases with atypical presentation. Over to you, ma'am.
Good morning, all. Today I am discussing 2 cases with because of their rare presentations. So in the first case, as we know that there are 3 basic types of congenital diaphragmatic hernias: posterolateral, Bogdalek, anterior Morgagni, and the hiatal hernia. Our first child is a 5-year male presented with frequent non-bilious vomiting immediately after feeds since birth. This is associated with lower respiratory tract infection since birth and failure to thrive. At the time of presentation, patient has tachycardia, tachypnea, SpO2 is 92% at room air with the malnutrition. On examination, there are no features of Down syndromes or any anomalies. Echocardiogram was within normal limits and chest X-ray shows opacity in the lower lung field, right side, with the air shadow at the right side lower lung hemithorax. Upper GI contrast study with water-soluble contrast shows gastric contrast in the right hemithorax, kinking of gastroesophageal junctions, grade 5 GERD, and we are suspecting torsion is this case because the stomach is a little bit horizontally lying. We manage the case on conservatively on prokinetics, frequent small rise to feeds, aggressive chest physiotherapy on which the child slowly responded, and URI is under control. CT scan shows a 2 into 2 centimeter defect in the substernal diaphragm with stomach, small bowel loops, and colon in the right hemithorax. Plain film CT also shows in axial view show that there is shadow. Air shadow is at the level of cardiac shadow that is confirms that stomach is inside the thorax. We did the surgical laparotomy via midline incision where 2 into 10 centimeter defect in the retrosternal space is repaired after reduction of the content with non-absorbable interrupted suture. We also did suture gastropexy in this case. In 2-year post-operative follow-up, the vomiting settled, child is gaining weight, and frequency of LRTI is decreased. So, Morgagni hernia is a retrosternal hernia of the abdominal contents through a diaphragmatic space. Overall, in children, it constitutes 3 to 5% of all diaphragmatic hernias. It can be congenital or acquired after median sternotomy, mainly for cardiac diseases. It is mostly right-sided, and omentum is the main content. Most cases are asymptomatic and present later in life due to the complications, or they are diagnosed incidentally for evaluation of disease for some other purpose. Acute symptoms in children could be respiratory distress or volvulus. Other symptoms might be mild respiratory tract infection or mild GERD type of symptoms. Morgagni hernia with gastric volvulus in an infant is a rare occurrence. Surgical approach is by transabdominal approach with interrupted non-absorbable suture. It can be done thoracoscopic also, or the laparoscopy is the gold standard. But we didn't do it because of surgical expertise. Then our case 2 is a 11-month-old female with history of recurrent hospital admissions for fever and non-productive cough, which has increased in frequency in the last This is associated with the failure of thrive and treated by pediatrician for recurrent pneumonia. General examination shows respiratory distress, and the right-sided there is abnormal findings are there. Laboratory parameters are normal with the minimal leukocytosis is there. A chest X-ray shows right lower zone opacity and there is reduced right hemithorax volumes and elevated right hemidiaphragm. CT scan axial view shows again liver at the same level with the cardiac shadow, with confirmed the elevated right hemidiaphragm is there and consolidation of right lower dome. We did the right posterolateral thoracotomy. The video is not playing.
Dr. Sunita, time is up.
Okay. So I just want to show that there the lower basal lobe is here is very dusky in color, and it has no aeration. We did the interrupted repair with non-absorbable suture from medial side to lateral side. Postoperative course was postoperative X-ray shows that the diaphragm pushed down to the one intercostal space down, and 2 years follow up the frequency of RTI is decreased significantly. So eventation is maybe complete or the partial complete eventation involves a part of the diaphragm, mostly it is right-sided, and the complete eventation is mostly left-sided. Causes can be phrenic injury, nerve injury due to many causes, or the neurological causes due to myelitis, encephalitis, neuralgia, tetanus, diphtheria. It's a surgical management indicated especially in infants because there is poor development of thoracic cage, weakness of the intercostal muscle. There is this decreased respiratory mobility of the diaphragm with the paradoxical movement of diaphragm, which causes pulmonary collapse, atelectasis, bronchial and parenchymal infection, and sometimes there is also mediastinal deviation is there. Ideally, it should be diagnosed by the fluoroscopy or real-time ultrasound with MRI. In asymptomatic, there are a controversy whether do surgical or conservative approach. Adequate time for surgery is still confusing after phrenic nerve injury because of most of the cases after cardiac surgery especially improves after 1 to 2 years of continuous follow-up. In children, it is considered that as the lung growth occurs up to the 10 years of age, so we must do the plication. There are various options. So augmentation is a clinical diagnosis that is challenging, but combined effort of pediatrician, radiologist, and surgeon can identify this difficult situation and can have better outcome. Thank you.
Sunita, any questions, please? Yes, Dr. Anjan.
Yeah, nice presentation, Dr. Sunita. Two queries. First, in the first case, how do you I would say commit that the LRTI was because of the small sized Morgagni hernia, which occupied less than 1/3 of the, why not a GERD concomitant GERD?
No, LRTI is because of the gastric volvulus. Because of that, patient is has repeated episodes of vomiting and aspiration pneumonia associated there.
So that's what I'm saying. Gastric.
So in my case, that MH is leading to these symptoms. Asymptomatic. Right. Usually these cases are diagnosed later on asymptomatic because that is rare. So
and in the second case, was a fluoroscopic or paradoxical movement of the diaphragm confirmed by either fluoroscopy or sonologically? Because then how do you differentiate from a phrenic nerve palsy or otherwise? I mean, both will have same kind of picture.
Yes, yes. But no pathological causes are identified in our case, and these facilities also not available.
It can be done with ultrasound.
So we did the CT scan and that confirmed actually that diaphragm is elevated.
Right. Thank you, Dr. Smita.
Thank you.
Thank you, ma'am. Now I call upon. Thank you, ma'am. Now I call upon Dr. Rohit Kapoor. He will be presenting on role of intraoperative enteroscopy in the management of small bowel pathology in children, technical details and surgical experience.
A very good afternoon to everyone. Today I'll discuss our, no, this is not the thing. Where is the presentation? Was there? Yeah, this. Yeah, sorry for that. Good afternoon, everyone. Today I'll present our technical details and our surgical experience of role of intraoperative endoscopy in management of small bowel pathology in children. So, as you all know, small bowel pathology is pose an exceptional diagnostic challenge, and especially in children, owing to their small size. There are a plethora of small bowel imaging techniques available to us, including device-assisted endoscopy and video capsule endoscopy, but the applicability is extremely limited in children. Intraoperative endoscopy offers a gold standard to assess the entire small bowel from mucosive, ulcerative, or vascular lesions. So the indications include, of course, GI bleed, multiple small bowel ulcer strictures causing bleed or obstruction, small bowel polyps causing bleed or obstruction, and foreign body removal. However, there are some contraindications which include hemodynamic instability and acute abdomen. So our aim was to review our surgical experience of intraoperative endoscopy in children with various small bowel pathologies. It was a retrospective chart review done during the period of 6 years, in which all the children under the age of 18 years who underwent intraoperative endoscopy for various indications in a single surgical were included, and all the children underwent small bowel evaluation by alternate means were excluded. Depending on their pathology and indications, thorough preoperative investigation protocol was followed, and preoperative hemoglobin and albumin were optimized before surgery, and routine bowel preparation was not used by us. So I present an index case of an 11-year-old girl who presented to us with chronic anemia and hyperproteinemia with malnutrition. Her hemoglobin and albumin were very low, and CT angiography showed the very dilated small bowel loops, and lower GI and upper GI endoscopy were normal. So after optimizing hemoglobin and albumin, we performed first inspection. After opening abdomen, we perform first inspection and palpation of the bowel, and as you can see, there is a very fat stranding present. Various marking sutures are taken at the site of presumed stricture. As you can see, multiple alien strictures are visible. We measure the length of disease small bowel to begin with, and then a pulse string suture is taken for enterotomy, as shown here. Now, after taking the pulse string suture, an enterotomy is made for introduction of the scope. Now, a flexible GI scope is introduced by the help of a pediatric gastroenterologist, and it is passed both distally and proximally. Now, this is the ileocecal area, as you can see. Now, when we trace the entire small bowel, now this is the intervening normal mucosa. Now, as you can see, this is a circumferential non-passable stricture that we encountered, and this is circumferential passable stricture. Now, post this procedure, the entire small bowel is emptied using suction, some suction, and then the measurement of residual small bowel is again done. Now, then the diseased small bowel is excised, and the residual small bowel is anastomosed end to end, as shown here. Now, coming on to the result, mean age was 10.3 years, and the most common indications were obscure GI bleed and multiple small bowel strictures. In all the cases, intraoperative endoscopy helped define the extent of disease. In 3 of our cases, we needed to do 2 enterotomies to visualize the entire small bowel. And we had a few complications, which were most of them were minor, but we had one recurrence of pathology that is stricture that we had to go in to manage. Now, coming on to the discussion, the
1 minute left, please.
Yeah, the advantages include complete bowel examination is possible in the same setting. The procedure is safe. It allows peritoneal, mesentery, and omental examination, and biopsy is required, and allows definite treatment of disease in the same setting. But there are a few disadvantages, which include anesthesia, laparotomy, and enterotomy-related complications, availability of endoscopy equipment, and endoscopist at the time of surgery, and inability to resolve mucosa in case of massive bleeding. Now, in conclusion, intraoperative endoscopy is safe and effective in children requiring small bowel pathology and provides a complete evaluation of entire small bowel mucosa. In our studies, it was the diagnostic modality of choice in cases of closed GI bleed, small bowel strictures, and Peutz-Jeghers syndrome. And it also helps to identify undiagnosed lesion and thus map the extent of disease intraoperatively. Thank you.
Thank you, Dr. While I understand the value of this intraoperative endoscopy in obscure GI bleeding and even in Peutz-Jeghers syndrome, but what additional information did you find in strictures? Something that cannot be seen from outside.
Yeah, so strictures, as you know, any that can be seen outside has to be dissected. That is established fact. But there are many strictures. There are some diseases such as CMEs that have circumferential ulcers that may result in stricture in future. by doing an intraoperatory we can actually identify the circumferential ulcers, and then we can actually resect that part of the bowel also, which we are not able to see from the outside. That's
right. Any other questions from the house?
In those cases which had lower GI bleed, what were the findings, like kind of cases? What kind of diagnosis? What diagnosis you had? Ultimate diagnosis, final.
So polyps.
No, in those having GI. Okay, polyps, right?
Yeah, and so the cases polyps, ulcers, circumferential ulcers were there. So there are the main causes. There was not specific histopathological diagnosis that was possible. Yeah. Thank you. Yeah. Yeah.
To extend this study to compare our on-table enteroscopy with the other modalities which can be done pre-operatively. Like if there is a GI bleed we are suspecting somewhere, can we better diagnose it with a CT angiogram, and we can straightway go for the surgery with a prior plan, which can further reduce the time of surgery.
Yeah, good
Dr.
question.
I don't think you need to answer that. Sir, sorry, please keep limited your questions to the presentation, not to the future studies.
Okay.
Thank you so much.
Thank you, Dr. Rohit. Now I would like to call upon Dr. Udit Kumar. He'll be presenting case series of esophageal foreign body with a rare case of esophageal foreign body impaction in previously operated type 3 esophageal atresia with tracheoesophageal fistula.
Good afternoon to all. I am Dr. Udit Kumar, Junior Resident of Department of General Surgery. I am presenting a case series of esophageal. I am presenting a case series of esophageal foreign body with a rare case of esophageal foreign body impaction in the previously operated type 3 esophageal atresia with tracheoesophageal fistula. Come to the introduction part. Foreign body ingestion in the children is very common and most occur in the between the 6 month and the 3 year of age. Notably, 80 to 90% of foreign body in the GI tract are passed spontaneously without complication, and 10 to 20% are removed endoscopically, and 1% requires open surgery secondary to complication. Most valid foreign body with harness passes through the GI tract, but some will lead to health problems if they become lodged, traumatize the mucosa, and caustic burn injuries. Types of the foreign bodies like coins. Coins are the most common ingested foreign body in the children. Another is button batteries can cause the severe damage. Second is the local hydrolysis and the action of the hydroxide on the mucosa. Sharp or pointed foreign bodies like safety pins associated with the high morbidity and the mortality. Larger long foreign bodies, ingestion of larger long foreign bodies in an issue of special concern. These foreign bodies must be removed within 24 hours because long or large foreign bodies are unlikely to pass through the duodenum and the ileocecal wall. In this study, we are reporting a rare case of 6-year-old female who came with a complaint of dysphagia following the foreign body ingestion. She had been operated for the type 3 tracheoesophageal atresia with the tracheal esophageal fistula. Patient did not have any symptom of dysphagia prior to this. Foreign body was lodged at the site of the previously operated anastomosis. Just chest X-ray. So these are foreign bodies. This is a collapsal bowel. It is found at the site of anastomosis. In method, we include 20 pediatric patients of esophageal foreign body ingestion attending pediatric surgery OPD. All patients underwent complete history and examination, radiologic investigation, and patient were then planned for the foreign body removal. A total of 20 pediatric patients were recruited with the history and the suspicion of the foreign body ingestion during the study period of 6 months. The majority of patients belong to 1 to 2 years of age, like the 9 patient, and the youngest one was 9 months and the oldest one was 6 years of age. The most common esophageal foreign body removed were coin in the 12 patient. Other foreign bodies were ring in 3 patient, button batteries in the 1 patient, organic food particles in the 2 patients, safety pin in 1 patient, and the collapse of hollow plastic ball was found impacting the previously operated type 3 esophageal atresia with tracheoesophageal fistula. The most common presentation as asymptomatic in 11 patients, followed by the dysphagia in 4 patients, sore throat and pain in 2 patients each, and nausea in the 1 patient. The most common site of the esophageal foreign body impacting the upper esophagus found in the 17 patient. In the case of the previously operated type 3 esophageal atresia with tracheoesophageal fistula, it was presented at T3 and T4 level. Discussion. Foreign body ingestion is a common emergency. The diagnosis and the management of the foreign body ingestion is most children are a challenge because of the difficulty in communication and examination when compared to adults. Alcalde and the colleagues observed that the foreign body was removed 93.8% and the only 5.4% pushed down to the stomach. Sometimes as the foreign body visible on an X-ray before the endoscopy passed to the stomach during the procedure. It happens in the 26 cases. Clinical symptoms accompany foreign esophageal foreign bodies depending mainly on the location, size and the time of the alert from the accident. Vomiting the case of the low esophageal foreign bodies because the pressure may cause the rupture of the thin wall of the esophagus. In little survey, a sore throat and the chest pain was essential and nagging symptoms. Lesinski reported that in the literature review, 7 to 35% of the patient had no ingestion symptoms, and finally endoscopy proved an impact object. Conclusion: the children with esophageal foreign body ingestions can be effectively treated. It is necessary to carefully consider the type of the ingested, the children's age, expected complication, and the emergency situations. Usually, site of the esophageal foreign body is at the upper end of the esophagus. One should be careful to remove a foreign body lodged at the previous esophageal anastomosis, as in this case. Thanks.
Thank you, Dr. Udit. Any questions, please? Seems there are no questions. Thank you.
Thank you.
Thank you for the nice presentation, Doctor. Now I would like to call upon Dr. Anju Verma, who will be presenting on Peutz-Jeghers syndrome, dilemma of surgery versus conservative management. Over to you.
शेयर कर दो.
Good afternoon, everyone. I'm Dr. Anju Verma from the Department of Pediatric Surgery, SGPG IMS Lucknow, going to present Peutz-Jeghers syndrome, dilemma of surgery versus conservative management. So Peutz-Jeghers syndrome is an autosomal dominant disorder occurred due to mutation in LKB1 or STK11 gene located on chromosome 19. It is 70% familial and 30% sporadic. Prevalence range from 1:8,000 to 1:3 lakhs. Has equal sex incidence, characterized by multiple hematomatous polyps in gastrointestinal tract, along with mucocutaneous pigmentation and increased risk of gastrointestinal and non-gastrointestinal cancers. As per WHO, the criteria for diagnosis is 2 or more Peutz-Jeghers polyps, any number of polyps with a family history of Peutz-Jeghers syndrome, or characteristic dark-colored spots with a family history of Peutz-Jeghers syndrome, or any number of Peutz-Jeghers polyp and characteristic dark-colored spots. So these are Peutz-Jeghers syndrome patients have high risk of numerous laparotomies due to polyps complication, and these are mainly diagnosed due to clinical manifestation secondary to the complications. So our aim is to present our difficulty during management of recurrent intussusception in patients with Peutz-Jeghers syndrome. Method, it was a retrospective study from January 2015 to July 2022. Data collected regarding presentation, management and follow-up with special attention on dilemma regarding the surgical versus conservative management. The total of 8 patients were presented during this time period and treated for recurrent intussusception. Median age was 9 years, ranged from 4 to 17 years. 5 patients were male and 3 patients were female. And they account for a total of 30 admission, average admission of 4 times with complaint of acute abdomen. Out of this admission, for 21 times they are managed conservatively, but for the 10 times we have to go for surgical intervention. Out of this, for 3 patients we have to go for resection and osmosis, and 7 times we have gone for reduction of the intussusception and polypectomy. Upper and lower GI endoscopy was done in all the cases, and intraoperative enteroscopy was performed when required. As per our criteria for conservative management, we have gone for when the patient have intermittent pain without significant vomiting or bleeding. The nasogastric aspirate was less than 100 ml per day, and intussusception length was less than 5 centimeter. And we went for surgical intervention when the patient was having persistent pain, significant vomiting or bleeding, and invariably required day surgery, and the persistent of intussusception even after 72 hours of conservative treatment. So as for Lashford et al., 40% of children and adolescents who required a laparotomy in less than 18 years of age, they invariably required a second laparotomy within 5 years of a polyp-related complication, and half of them required it within a 2 year of first laparotomy. So in the conclusion, considering the diffuse involvement of gut, early decision of surgery and extensive resection should not be done in Peutz-Jeghers syndrome. Conservative treatment must be tried under close observation. Treatment is directed in the form of limited resection or polypectomy after reduction of intussusception if the surgery is needed. Thank you.
Thank you, Dr. Anju. Have you ever encountered a situation when there are multiple intussusceptions and it was difficult to decide what was the what was the point that was leading to symptoms, and what did you do in such a situation? Did you remove all the polyps that were causing intussusceptions?
So if you are able to, in the cases of multiple polyps, we went for enteroscopy, and we went for clean sweep procedure, and we remove all the polyps.
My question is that it is not unusual in Peutz-Jeghers syndrome to find multiple interceptions,
yes, sir,
and they may not all be symptomatic. So what did you do for those interceptions when you went in? Did you did polypectomies at every site?
If the polyps are causing interception, we will remove that polyps.
All of them?
Yes, sir.
Thank you.
Yes, sir.
Yes. Yes.
And I think you your favorite intraoperative endoscopy. Capsule endoscopy was much better because the can actually count the number of polyps there are and from the slide the aggressive and
Can I ask a question? How do you plan the follow-ups for these patients, both the operated and the conserved ones?
So we follow them with the upper GI and lower GI endoscopy. Along with if the need of there is, we can go for enteroscopy also. We have a gastro department, so every 2 yearly the patient are called for upper GI and lower GI endoscopy. And if they are polyp, they can be removed endoscopically, then well. Otherwise, if they are causing symptom and cannot be removed endoscopically, we will go for surgical intervention.
2 years, not accurate.
2 years, after.
And your follow-ups included only endoscopies or other investigations?
Other blood investigations, ultrasound, etc. We will have to see. Thank you.
Thank you, Dr. Anju. Now I would like to call upon Dr. Rahul Dio. He'll be presenting Balloon venoplasty as primary modality of treatment in children with Budd-Chiari syndrome.
Once again, thank you for giving me this opportunity. So this series is about a Budd-Chiari syndrome. We have a series of 35 cases over the period of 15 years. So the 35 cases that we have, 20 were boys and 15 were girls with a median age of 30 months. And all patients, almost 89% presented with ascites and hepatomegaly, while 88% were having abdominal distension and pain. Splenomegaly was there in 66% and the dilated abdominal anterior wall veins were there in 60%. For the lab investigation that we did on blood workup, LFTs with the coagulation profile, the mean SGOT levels were high, 121.5 international unit per ml, while the mean SGPT was 62.6 international unit per ml. Protein C and protein S deficiency was there in 9% of the patient, while APLA was present in 1 patient. We did radiological M-mode Doppler ultrasonography and MR venography, in which hepatic vein obstruction was there in 85% of the patient, while both IVC and hepatic vein obstruction was in 15% of the patients. I have written a line here as a misdiagnosed tuberculous ascites, and specifically I have written M-mode Doppler ultrasonography. Why I have written? Because some of the times when we do only Doppler with the ultrasound, we tend to have all these things: enlarged caudate lobe, sometimes non-visualization of hepatic veins, compressed IVC, forward flow. But falsely, we can also have patent hepatic veins that will misdiagnose the case of Budd-Chiari syndrome as a tuberculous ascites. And as we have seen in UP also, the tuberculous ascites is much more prevalent as compared to the Budd-Chiari syndrome. So if a patient of Budd-Chiari is misdiagnosed as tuberculous ascites, they will have AKD throughout the time, and they will not be getting treated. And once the treatment is getting late for a Budd-Chiari syndrome, patient will not survive. So this is a M-mode Doppler that I am talking about. So a normal, we can see a normal triphasic waveforms in a patent hepatic vein, while a patient with a Budd-Chiari syndrome have a monophasic waveform in hepatic venous occlusion. So this is the MR venography picture that I am showing a blood filling defects in inferior right hepatic vein, that is the white arrow one can see, while the IVC is from the black arrow showing the partial thrombosis. For treatment of all our cases, 1 case deceased while awaiting treatment, 2 cases were having spontaneous recovery, while the next 32 cases we have done venography followed by venoplasty and portocable shunting. Out of these 32 cases, 5 cases we did venography only, as hepatic veins could not be cannulated, while 25 cases did with the transjugular venoplasty. 2 cases we did transhepatic venoplasty, and 4 cases portocable shunting post unsuccessful venoplasty. This is the picture showing percutaneous venoplasty by the transjugular route. So by intrajugular puncture, we found the obstruction at the hepatic veins and calculated the pressure gradient across the narrowing. We have dilated with the balloon dilator. This picture is showing that, and the gradient reduced after the dilatation. And this is a picture post dilatation. And we did a liver biopsy along with that percutaneous venoplasty. In the patient in which that intrajugular route was not feasible, we did transhepatic venoplasty. This is the picture for the same. And this is a picture showing portocable shunting in which percutaneous venoplasty was filled. For the follow-up, just post procedure, we have started with the heparinization of the patient. After that, we'll start with LMWH with monitoring anti-factor 10th level and warfarin on discharge. PT INR was maintained between 2 and 3, and propanol was started to minimize bleeding risk from the portal hypertension. MR venography was done post procedure after 1 year follow up, and no block and anticoagulant was stopped after the procedure if we find, and further follow up for the yearly and symptoms recurrence. The result we had, average age intervention was 29 months, 14 were alive and symptom free, out of which 1 was having spontaneous recovery, 11 was successful transjugular venoplasty and opened at least 1 blocked vein,
Well, the two transhepatic venoplasty followed by tips and liver reimplantations. The patient we have disease was 9 disease and 12 lost to follow. Well, this is the algorithm that we have devised. Whenever a child is presenting with the symptoms, we did a M-mode Doppler with the MRV and diagnosed the patients and planned for balloon venoplasty. We have 3 choices here. If it was successful, then we started with the same heparinization follow-up. If we are unable to cannulate the hepatic veins, perform a liver biopsy. And if venoplasty is unsuccessful, that biopsy is showing congestion of liver without cirrhosis, we go for the portosystemic shunting. If biopsy is showing cirrhosis, we'll counsel them for liver transplantation. So Budd-Chiari syndrome is by the name of George Budd and Hirschsprung. Those are the pictures of the gentleman. It is characterized by occlusion of venous outflow from liver at the level of hepatic veins and inferior vena cava. To conclude, I would like to say that hepatic ascites with hepatomegaly predominates the presentation of Budd-Chiari syndrome. Liver functions are mildly deranged in early phase. MR venography is a good diagnostic test, and balloon venoplasty is a satisfactory modality to manage these patients and could be performed through a transjugular and transhepatic routes. These are papers for Budd-Chiari syndromes. Thank you.
Question, please.
Technically, they have to get a cardiac and I have not had personal experience. From Howard, I always there is the jugular, but I found a aortic graft. Yes, so we were not doing it in the given. And fortunately, most of the patients that we encountered were having blocked at hepatic cells. And we have mentioned that because they are not able to block.
Thank you, sir.
Thank you, doctor. Now I would like to call upon Dr. Devendra Chaurasia, presenting paper on spontaneous gastric perforation in neonates and enigma.
Good afternoon, everyone. And greeting from the Himalayan Institute of Medical Science, Joligrant, Dehradun. I am Dr. Devendra Chaurasia, Junior Resident of Department of Surgery. And thanks a lot to the Dr. Yasir Ahmed Lone, who gave the opportunity to present on this podium. I am presenting a spontaneous gastric perforation in the neonate and enigma. A gastric perforation is a life-threatening situation, though it is a rare occurrence in the neonates. It's related with the high mortality and high morbidity condition. High mortality and high morbidity condition. Over the 200 cases are reported till now. After the first case was reported by the CIVOLD in 2025. I am presenting a 4-day-old male child who is a full-term vaginal delivery at a home and cries just after the birth and passes the Meconium within the 4 hours. And no adverse perinatal event happened. I presented to our emergency department with the complaint of abdominal distension and the 1 to 2 episode of the vomiting. Patient was in the respiratory distress, but no sign or symptom of the hypovolemic shock. And on abdominal examination, patient abdomen was distended, tense, tender, and bowel sound was absent. Genitalia was normal, anal opening was normal, and anus was stained with the Meconium. After the initial resuscitation, we forward for the radiological imaging study, erect abdominal X-ray, which was suggestive of the gas under both of the hemodiaphragm. after sending the basic investigations and adequate resuscitation, we took the patient for the emergency laparotomy. And during the laparotomy, we found that the bowel was healthy from the duodenojejunal flexure to the ileocecal junctions, and the greater curvature of the abdominal wall is greater curvature of the stomach was also normal, and interior wall is also normal. The omentum is almost necrosed, and through them after the going through the omentum, we go to the lesser sac and examine the posterior gastric wall. There is a perforation of 0.5 mm on the posterior wall of the gastric wall. This is a clinical course of the my patient. After the exploratory laparotomy, patient who could not be extubated with a respiratory compromise. Patient was intubated till the post-operative 18, but we initially start the OG feed as the NG output was decreases, bilious decreases, and bilious output is changed to the normal mucosal normal secretions. And patient was successfully discharged on the post-operative day 28 after the extubation, and we put the patient on the CPAP mode for the due to the respiratory compromise. Once the patient is stabilized, and we put the patient into the step down position, and patient finally accepted the breast feed normally and can hold the breath. We discharge the patient in satisfactory condition. The incidence of the spontaneous gastric perforation is a 1 in patient 209 live birth, and the mechanism was proposed to the traumatic and ischemic or spontaneous. The traumatic perforation is seen in those patients where the instrumentation like the placing the NG tube, bag and mask, over-intrusive bag and mask was done. In these cases, traumatic perforation was seen. Ischemic condition is seen in those newborn in which the physiological stress was there, such as a sepsis.
Please conclude.
My discussion is ending with this. My child is fall in the category of spontaneous perforation. Due to the it's a healthy born child and no healthy born child full term, and the no adverse event occur in the posterior. The spontaneous perforation, the one hypothesis related with this is only that this situation is there is a circular muscle in the posterior abdomen which is less developed in the child, have a multiple gaps. This may be lead to the spontaneous perforation. Thank you.
Thank you, Dr. Bevin. Any questions, please?
Yes, sir. Enigma word is that first case was reported by Seibold in 1825. Last literature I found is printed in the because etiological factor could not be found till now, sir. Yes, sir. Yes, sir. So that's why I presented this case to search of the etiological factors, sir.
Yes, Dr. Anjan.
Dr. Devendra, you didn't mention what did you do after doing laparotomy, after like what was the final procedure that was done, and did you send any biopsy or not?
We fashioned the margin and
so that
primary
you
repair
didn't
was
mention.
done and biopsy was done for the histopathological.
Right. Thank you, Dr. Charasi.
Thank you, doctor. Now I would like to call upon Dr. Rohit Kapoor, who will be presenting chronic gastric volvulus in neonates and infants, experience from a tertiary care pediatric center in North India.
Good afternoon, everyone. Today I will be presenting our experience with chronic gastric volvulus in neonates and infants. Now, this is my declaration. Now, gastric volvulus can be defined as stomach rotating more than 180 degrees around an axis leading to a gastrointestinal obstruction. Now it's an extremely rare pathology, which can be noted from the fact that in a recent systematic review published in a reputed journal, out of the 97 papers, which consist of mostly of case reports and case series, only 125 patients were included, and this is data of 10 years. So it can be of various types based on axis of rotation. It can be organoaxial, mesenteroaxial, or combined. Based on the mode of presentation, it can be acute or chronic, and based on etiology, it can be primary or secondary. Now, the chronic gastric volvulus generally presents with non-specific symptoms, signs, and radiological features, which makes the current diagnosis often difficult and which leads to delay in treatment. Now, our aim was to highlight the several signs present on plain X-ray, which may indicate a diagnosis prior to the confirmation on upper GI contrast study. So it was a retrospective chart review done during 3 years, in which all the neonates and infants operated in our institution for primary chronic gastric volvulus were included, and all the patients more than 1 year of age and elsewhere operated cases were excluded. And data was collected. Now to declare that we became aware about the several signs on plain X-ray in retrospect during the literature search after the diagnosis of first case, and this helped in diagnosis of our subsequent cases. Now, in all the cases, diagnosis was confirmed by upper GI contrast study. Now, coming on to results, the mean age was 4.7 months and mean weight was 4.5 kgs around. All the babies were term babies except one, and most common presentation was feed intolerance. So these are the few of our cases with plain X-ray of our cases. As you can see in the first case, there is a horizontal stomach gas shadow. In the second case, there is a large gas shadow in the left upper abdomen. In the third case, there is epigastric gas shadow, and in the fourth case, there is a gastric distension despite nasogastric tube in situ. Now, as you can see, in all the cases, there is a masking of the radiopaque shadow of the left lobe of liver, which I will describe in detail later. Now, coming on to the upper GI contrast study, which was done in all the cases, this is one of the representative study in which the stomach is horizontal. There is lowering of the gastric fundus. GE junction is lower with GER. There is reversal of greater and lesser curvature. The greater curvature is crossing the esophagus. There is free flow of contrast into a small bowel, and the pilus is pointing downwards with delayed gastric emptying. Now, as shown in the diagrammatic representation, all our cases were of organoaxial volvulus without any diaphragmatic anomaly. In all the cases, at first, conservative management was initiated, but in 3 of our cases, we had to revert to surgical management in form of feeding gastrostomy. Now, coming on to the discussion, the organoaxial gastric volvulus is regarded as most common type in literature in chronic cases, and it's true in our series also. And it is this type of primary chronic gastric volvulus which pose a diagnostic challenge. And in our present series, we tried to highlight the certain signs on plain X-ray and upper GI contrast study leading to preoperative diagnosis. So, coming on to the plain X-ray signs, the gastric double bubble is specific to organoaxial gastric volvulus. It is due to air trapped into overlapping gastric chambers created by folding of greater curvature of stomach superior to lesser curvature. The gastric distension, despite nasogastric tube, is because only the proximal part is decompressed on putting the NG tube. The masking of radiopaque shadow of left lower liver and horizontal stomach gas shadow is because stomach rotates around the longitudinal axis and it tends to lie in a horizontal plane. And the large gas shadow on the left side of abdomen is due to the inability of stomach to decompress in organoaxial gastric volvulus. So, although the diagnosis was confirmed in our cases with upper GI contrast study, but CECT can also be done with preferred over contrast, as it provides better delineation in these cases, although it was not done in any other cases. Now, this treatment is mainly conservative. It's tried first, which was done in all our cases, but ultimately, in most cases, you have to go for surgical management in form of derotation gastropexy or with or without feeding gastrostomy. So, in conclusion, due to non-specific presentation, the diagnosis of this extremely rare disorder remains a challenge, and it should be suspected in any newborn presented with feed intolerance, non-bilious vomiting, epigastric distension. Upper GI contrast study confirms the diagnosis, but there are few several signs present on X-ray which should be looked. Surgical procedure is anterior gastropexy video without gastrostomy, and prognosis generally excellent with timely diagnosis and treatment. Thank you for the patient hearing.
Thank you, Dr. Rohit.
Yes.
You're always wiser after the surgery, but were you actually able to suspect gastric volvulus just based on the plain X-ray?
So in the first case, as I declared earlier, in first case we had no clue actually. We were not suspecting the presentation was really non-specific. So we were thinking GER and all that sort of things. But after the first case, when we searched the literature, we found there are subtle signs that on which we can suspect that I described here. The masking of the left lobe of liver by the...
No, that's fine. Yeah. I'm asking you, in your subsequent cases, were you able to suspect it on plain X-ray ever?
Yeah, we were able to suspect it. We had to obviously confirm it by upper GI contrast study. Yes, sir.
The operation that you performed is only a gastrostomy.
Yes, sir.
You did not do gastropexy. Is that correct?
Yes, sir.
But you mentioned that in the discussion that it is an option. So why did you choose to avoid it?
Sir, there are a couple of reasons. First of all, both of them achieve the same thing. You have to fix the anterior wall of stomach to the parietal wall.
No, I disagree with you there. Yes. In a gastropexy, it is fixed at 3-point fixation.
Yes, sir. That I agree.
In a gastrostomy, it is 1-point fixation.
But sir, that fixation stays there for around we took out the gastrostomy in most of the cases at around 20 days around. So that leads to a fixation, the fibrosis and fixation.
Yeah, but it is 1 point, so it still can rotate around that point. That's my issue. See, with a gastropexy, when it is like testicular torsion.
Yes, sir.
You don't take 1 stitch, you take 3 stitches.
Yes, yes.
3, 9, whatever.
Yes.
So that is the reason. See, otherwise you could have taken 1 stitch for testes also.
Yes, sir. Okay, sir. Okay, I'll look into that, sir. Yes, sir.
Dr. Anjan.
Rohit.
Yes, sir. So basically, thickening of feeds is tried, and prone nursing and upright feeding is done. So that is the diet certification that we followed, and we give PPIs, anti-secretory drugs, PPIs to these children, and we also have tried domstol or domperidone and metoclopramide also in these patients. So.
I have a quick question. Dr. Rohit, excellent presentation.
Yes,
I just wanted to know how much time you give for conservative management, and when do you decide for going for surgery?
Yeah, that's a good question, sir. Actually, we give at least 72 hours. We see whether the patient is improving or not improving. We are able to feed the child or not. We are not able to feed the child. We anyways put the child on small feeds. Sometimes we used to put them on continuous NG feeds, and we have to see whether they are responding to treatment or not. If they are not responding, we used to go forward with the feeding gastrostomy. Thank you, sir.
Thank you so much, Dr. Rohit. Now this brings us to the end of session 1. I once again thank all the chairpersons for moderating the session. I request all the chairpersons to kindly come out on the stage for a group photo session. Thank you, sirs. Okay. Okay, moving on to the last session for the day. It's a short oral presentation. It will be for 3 + 2 minutes, and for which I would like to call upon the chairpersons. I request Dr. J.D. Rawat sir, Professor and Head, KGMU Lucknow, to kindly grace the dais. I also request Dr. Deepak Kanpal sir, Senior Consultant, Pediatric Surgery, Apollo Hospital, Lucknow, to grace the dais. I request Dr. Achalasia Roy sir, Senior Consultant, Pediatric Surgery, Lucknow, Dr. Shrikesh Singh, Sir, Associate Professor, RML, PGMER, Lucknow, to kindly grace the dais. Thank you, sirs. Thank you, Aditya. Next, Anjali Jalan.
First 3 minutes plus 2 minutes for discussion. And we try to take the time. There are 5 papers, so we'll just quickly finish before the validation and board of time.
Okay. The first, welcome, sir. And the first paper for this session is by Dr. Anjali Jalan, ERAS Lucknow Medical College and Hospital. Dr. Anjali will be presenting on Litter's hernia, a case report. Over to you, Doc.
Thank you, ma'am. Good afternoon to one and all present here. Special thanks to Dr. Professor A.K. Roy, sir, who is my mentor. Introduction. Meckel's diverticulum is the most common congenital anomaly of the gastrointestinal tract. It is the true diverticulum, and it is predominated by the rule of 2, as we all know. Its prevalence is 2%, and it's usually discovered before the age of 2 years. It is located within 2 feet from the ileocecal valve. It is 2 inches long and 2 centimeters in diameter. Mostly 2 types of heterotrophic mucosa are present. It is 2 times more common in males. Surgical anatomically, measurements are variable, and its length has been reported to as short as 1 centimeter and as long as 26 centimeters, but usually 3 to 6 centimeters long. Meckel's diverticulum has been encountered in diverse hernias, which incidence is very low, that is 1%, out of which inguinal is the most common, followed by umbilical and femoral. Treatment of the Meckel's diverticulum points out that the most complications occur before the age of 30, recommending no resection after this age. It could be present as an acute emergency like bleeding, obstruction, incarceration, perforation, or diverticulitis. I am here to present a case of 3 and 5 years old child respectively, presented to the pediatric surgery clinic with lump in the right inguinal region and vomiting. Abdominal distension with unilateral oval lump of approximately 3 to 2 centimeters in the right-sided inguinal region was found, which was partially reducible, which increased in size during coughing and crying. For the confirming the diagnosis and planning, sonography was done. Diagnosis of the right inguinal hernia was made, but the contents of the sac couldn't be differentiated from the intestine. Intraoperative findings. The case 1, adhesion was found. Meckel's apex adhered to the scrotum. These adhesions were removed. Ileal wedge resection with primary end-to-end anastomosis was done. More photographs from the intraop adhesion band extending from the apex of the Meckel's diverticulum till scrotum. Reduction of the content back in the abdominal cavity and the resection and anastomosis of the ileum. In the case 2, the perforation of the junction of the Meckel's and the normal bowel, for which resection and anastomosis was done with the repair of hernia. The results were as follows. The bowel sound was present on day 2 and 3. The oral feed started with the day 5 for both the patients. The patient was discharged on day 7. We had sent the HP for the same, which showed multiple foci of mucosal invagination deep into the muscularis propria, along with intact architecture of the intestinal wall, no evidence of granuloma or malignancy, and impressions were consistent with the clinical diagnosis of the Meckel's. Discussion. The Litter's hernia is an incidental finding, difficult to diagnose. Asymptomatic Meckel's diverticulum incidentally found within a hernia sac should be resected because of the possible presence of ectopic mucosa. The known treatment is a wedge resection. In the complicated Litter's hernia, ileal resection and anastomosis should be done. On conclusion, although the Litter's hernia is a rare complication of Meckel's diverticulum, but since it is difficult to diagnose preoperatively, it should be kept in mind when small bowel resection has been done so as to avoid complications. Thank you.
Thank you, madam, for a nice presentation. Any query from the audience? Most welcome. Any comment? It's a basically accidental finding in inguinal hernia that can happen. And the only things I would like to ask you, that suppose if you are doing a laparotomy or you are doing laparoscopy and you are getting a such wide neck that mucous diverticulum, what will be your approach? Will you leave it or you will go for surgical?
So I will dissect it.
Why? What are the indication to go in and to do the mucous, although it is a little bit away from your topics?
Sir, as it is seen that the gastric mucosa or the can be present. So
how much percentage you will get? Gastric or pancreatic?
So the pancreatic is the most common and the followed by the gastric.
Normally it is said that in laparoscopy or in laparotomy for getting a wide neck, this mucous diverticulum, and on feel if there is no thickness, nothing, then you can leave as such, there is no need to excise. And complications that can happen that you have already told. Thank you.
Thank you, sir.
Thank you, Dr. Anjali. I would like to now call upon Dr. Ankit Kasundra, who will be presenting on choledochal cyst surgery in a case of extrahepatic portal venous obstruction.
Okay, yes. सबसे पहले
Second next.
Good afternoon to all respected faculty. I am myself Ankit Kasundra, semi-resident pediatric surgery AIIMS Bhopal. I am presenting a rare and challenging to treat a case of choledochal cyst surgery in extrahepatic portal vein obstruction. Choledochal cyst present with variety of complication, but portal hypertension is a rare presentation. It doesn't know any clear guidelines how to manage this case. In this, we do first portal hypertension treat or we do cyst excision. In choledochal cyst with portal hypertension, there is no complete excision, may not be feasible due to the massive collateral developed around the choledochal cyst and porta. My case, 5-year male child refer outside with suspicious pancreatitis. After admission and resuscitation, evaluation diagnosed as a ruptured type 1 choledochal cyst with biliary peritonitis. After exploratomy, we found all biliary system are inflamed and edematous. So we do cholecystostomy was done and peritoneal lavage is given. After the post-op day 8, we discharge the patient with cholecystostomy and give definitive date for treatment after 6 weeks. During the follow-up, patient developed 2 episodes of cholangitis, which was managed conservatively. This picture shows choledochal cyst with subhepatic and peritoneal fluid. It is biliary peritonitis. During second surgery, intraoperatively, we found the picture of portal hypertension with portocavernosoma over the choledochal cyst. So we limited excision of cyst with cauterization of remaining mucosa with Roux-en-Y hepaticojejunostomy was done. On post-op day, patient developed anastomosis fracture, anastomosis leak due to we take only 3 stitches in posterior because of heavy bleeding from cavernoma side. And anastomosis leak treat conservatively. CT after
After second surgery, we review our previous CT scan. In CT scan, we find out the portal vein thrombosis, but we missed the portal vein thrombosis in this CT because we follow routine USG. In USG, no any picture show portal hypertension, picture of portal hypertension and cavernoma formation, and we also we did not expect the portal hypertension in choledochal cyst, so we performed the cyst excision, but it is not possible due to the portal cavernoma and portal hypertension feature. Incidence of portal hypertension in choledochal cyst infantile variety it is usually, but portal hypertension incidence in adult variety of choledochal cyst it is unusually, but some study and literature show higher incidence of subclinical portal hypertension is present in adult variety of choledochal cyst. Why portal hypertension developed in choledochal cyst? It is due to the choledochal cyst itself. It compresses the portal vein and also it produces secondary biliary cirrhosis and Carroll's disease which produces portal hypertension. But in unusually cause of portal hypertension, it is due to the development of portal vein thrombosis. Portal vein thrombosis it is developed due to the recurrent cholangitis. So management is at present no any clear-cut guideline, but we can manage as per cause and degree of liver damage. In the cause, if portal hypertension is developed due to the cyst, so we partial or complete excision of cyst with biliary enteric anastomotic, which improve the portal hypertension over time. But it is produced by the portal vein thrombosis. It is difficulty to decide how to do first. We do sun surgery first or we do cyst excision first. In the aspect of the degree of liver damage, if the decompensated liver present, so we plan for liver transplant also. In our case, the cause of portal hypertension it is a portal vein thrombosis may be developed due to the biliary peritonitis. In the future plan of our case, if portal hypertension is aggravated, he will advise for sun surgery. But in the portal hypertension is subside. In subside, how to manage this patient because can I see the patient and do laparotomy and check the if viable mucosa is present and it is excited, it is possible or not. The portal hypertension with choledochal cyst, it is challenging to manage. Thorough pre-op evaluation and look for liver failure or evaluation to excise the choledochal cyst or not. Most of case, biliary enteric drainage should be performed rather than sun surgery at the first. And we also plan step down approach in choledochal cyst with portal hypertension and need a regular follow-up of patient. Thank you.
Thank you, dear, for your nice presentation. Any query?
Ankit, nicely managed. What was the liver biopsy in your case?
Sir, we don't take a liver biopsy because intraoperatively liver is normal and no any USG or a CT scan finding have a liver cirrhosis. So we don't need take any biopsy. Sir, in anastomosis leak, we manage conservatively by the subequatric drain and nil for error and then give TP answer. Yes, sir, settle in. Post of the age, sir. We discharge the patient post of the age.
I would have done the first surgery first. But if you have a then you can bring the portal down by 5 minutes.
Yes, sir.
That can significantly reduce the and make the direction of the corridor. And if you have a digital is better to drain the cyst rather than to work?
Yes, sir. So we
in
yes, sir. So we do only cholecystomy with Foley's catheter.
Thank you, dear. Now we proceed to next paper.
Thank you, doctor. Now our next presenter is Dr. Shalvika Kashyap from Himalayan Institute of Medical Science, who will be presenting on rectal duplication presenting as a perinatal mass, a rare presentation.
Good afternoon, everybody. Greetings from Uttarakhand. I, Dr. Shalvika, resident of general surgery, is going to present an interesting case on rectal duplication. 1.5-year-old female presented to us with complaints of a fleshy perineal mass since birth. On examination, there was a fleshy perineal mass of approximately 4 into 3 centimeter occupying the introitus and displacing the urethral and vaginal opening. All 3 normal openings were present and no other anomaly was detected on physical examination. First, we did an ultrasound, which was normal. Then MRI pelvis was done to see the extent of the mass, which was also reported to be normal. Then, so we went ahead with the biopsy, which was suggestive of a large area with focal ulceration with neutrophilic exudate and areas of squamous metaplasia. Then patient presented to us after several weeks, and on examination, the edema had substantially reduced and an IFT was passed through the opening for approximately 5 to 6 centimeter. Patient also gave the history of occasional mucoid discharge. So at this point, there was a possible diagnosis of bowel duplication was kept. Then we did a barium enema, which showed a normal rectum, and there was no communication with the lumen in question. So working diagnosis of rectal duplication was kept and patient was planned for excision. Intraoperatively under CIAM guidance, one flatus tube was passed in the normal anal opening and other flatus tube was passed simultaneously into the duplication to know the communication, to know if the communication and the extent of the tract. Then mass was circumscribed and dissected close to the bowel wall. After the initial dissection of only few centimeters, the mucosa was dissected and entire mucosal tube was removed. This is the finer picture showing after the tube was excised. Then the wound was irrigated with NS and closed in layers over a glove drain. This is the gross specimen showing a tubular structure measuring approximately 7 centimeter into 1.2 centimeter. And microscopic examination, this is a low power view showing focal with all layers, showing all muscular layers and showing focal areas of muscle hypertrophy. This is the high power view showing several lymphoid follicles with a prominent germinal center, which corresponds to colonic epithelium, confirming our diagnosis. This is the histopathological report. Now patient is under follow-up with no new symptoms and doing well. We present this case because, as you know, that rectal duplications are very rare, and its unique presentation in this case presenting as a perineal mass. Rectal duplications usually present with symptoms of obstructions, urinary symptoms, or may be present as rectovaginal fistula also in females. Duplications can be present anywhere between mouth to anus, with most common site being the ileum and the jejunum, followed by the esophagus. Rectal duplication account only for 3% of all the duplication. And in this case, they are difficult to diagnose. So customized imaging usually allows us to see the anatomical details. And treatment too also depends on several factors, including the location, communication with the parent bowel, and complete excision of the mucosa is the aim and is curative. Thank you.
Shivalika, any
Thank you,
questions
sir.
from the audience?
You have done only barium enema. You could have done some other imaging investigations to confirm the diagnosis.
We have done barium enema and we have also done contrast studies, but we could not take the picture for the same. So in the contrast study, through the normal rectum, we have given gastrographin and barium in the normal anal opening and gastrographin to the anal to see if there is any communication or if it's there communication and to know the extent of the mass.
But barium enema was absolutely normal, so that mass could have been something else also. So
yes,
you could have better delineation before going to surgery.
So, but as you can see, in the other imaging we have done under CM guidance, the two Hagar dilators, the two flatus tubes are seen intersecting each other. So, that was a probable possible effect. Thank you, sir.
Thank you, Dr. Shalvika. Now I would like to call upon Dr. Surendra Singh from Lilavati Hospital and Research Center, Mumbai, who will be presenting on GB duplication with choledochal cyst, an unusual case of biliary anatomy.
Yeah.
Yeah. Good afternoon, everyone. I am going to present a double gallbladder and unusual biliary anatomy. 4-year, 3-month-old male child presented to us with upper abdominal colicky pain, fever, non-bilious vomiting. Child has same history, similar episode 1 year back. At that moment, USG done, that reported double GB. On examination, child is sick looking, ecteric, vitally stable. On per abdominal examination, tender and gardening is present. On blood investigation, serum amylase and lipase raised, and in USG reported acute cholecystitis of both gallbladders. MRCP reported CBD with intraductal calculi and type 2 choledochal cyst with prominence of intrahepatic duct was seen. Perihilar lymph node enlarged. There is a double gallbladder and dilated dilated CBD. In MRCP, we can see intraductal calculi in CBD. There is a feeding defect. In intraoperative, we clearly seen that 2 GB and both separately cannulated with scalp vein, and we put contrast. Under CM, we can see a 2 GB separately and a dilated CBD. We dissected both GB along with dilated CBD. Here, hepatico-docogenostomy done. And intraoperatively, we have seen that the presence of Meckel's diverticulum and spleniculus over here. Fitz classified double GB in two parts, split primordial gallbladder, that is septated V type and Y type. We have in our case B type, and accessory gallbladders H type, trabecular and triple gallbladder. It's a descended sample for histopath. And the exact ecology of choledochal cyst is still unclear. Some researchers believe that pancreatic juice reflux into biliary tree plays an important role in choledochal cyst formation. An anomalous pancreatico-biliary ductal junction or a sphincter of Oddi dysfunction can cause pancreatic juice reflux. On conclusion, a case of gallbladder duplication with common pancreaticobiliary channel with a type 3 choledochal cyst, Meconium diverticulum and spleniculus. MRCP is a useful tool to delineate the anatomy in such complex biliary anomalies, and cholecystectomy with disconnection of biliary system from pancreatic system helps in resolution of such anomalies. Thank you so much, sir.
Thank you, Dr. Suren.
Thank you, sir.
For a nice presentation. Now, paper is open for discussion. Any question?
What is the embryological basis explained, available in literature? Is there a mention of it?
Sir, it's not clear much, so we not mention it. In the
No, not you. I mean, is it available somewhere?
Not much, sir. Sir, we considered that moment. So we kept child for NBM 7 days and we monitor regularly that CME amylase and lipase. Once it came down, we go further our definitive procedure. We go ahead for that. We considered as acute pancreatitis for that moment because of CME amylase and lipase raised.
What about the main pancreatic that
Yes, sir. So that so we did nothing for that. We just followed patient clinical condition, and now child is doing well, fine. Yes, sir. Yes, sir.
Was not mentioned. Maybe not inadequate. There is a stone at the lower end. Okay. Next MRC.
Sir, this one?
Here, okay.
Yeah. Yes, sir.
You can see that stone. And then you can see the magnetic. There was a common magnetic. And there was not whether proximal dilation because of the stone. But then it was interpreted on the MR as a choledochal cyst. And the histopathology for evidence that there is ulceration.
Thank you, sir.
Thank you, Dr. Surendra. I would like to call upon Dr. Rahul Kumar Rai to be presenting on a rare cause of duodenal obstruction, Budd-Chiari syndrome.
Good afternoon, sir. I am presenting a rare case of superior mesenteric duodenal obstruction. 11-year-old female presented with us with a complaint of persistent dull epigastric abdominal pain, severe bloating, loss of appetite, early satiety, and postprandial fullness, on and off bilious vomiting that has worsened at the time of presentation. At the time of presentation, vomiting was variable with episode occurring once a week to up to 3 times a day and happened mostly after meals. Had been treated at another hospital with proton pump inhibitor, analgesic and intravenous fluids. On general examination, patient weight is 20 kg, which is less than 50th percentile as per age. Dehydration present. Sign of dehydration like sunken eye and dry skin. Pulse rate was 110 beats per minute. BP is 96 60 millimeter of mercury. No pallid cyanosis or clubbing are present. On investigation, patient hemoglobin is 13.3 gram percent and TLC is 9600. Urea, sodium, and electrolytes are within normal limit. On radiological examination, ultrasound, a single dilated loop with enlarged mesenteric lymph node suggestive of infective or inflammatory pathology. But on X-ray abdomen, rise tube reaching up to the umbilical level. On upper GI study, grossly dilated stomach with narrowing at duodenum was present. Dye retained in the stomach up to the 1 hour. Gastrointestinal barium series shows severely delayed transit through the third part of the duodenum, consistent with a partial bowel obstruction. On CT, the relation of SMA and aorta was seen. After initial stabilization, exploratory laparotomy was planned and performed on 9th February 2022. On Paraff finding, a dilated stomach and duodenum was encountered. Severe fibrosis present at the third part of the duodenum. Pulsatile structure encountered at the third part of the duodenum, which is superior mesenteric artery, which clamps the third part of the duodenum. These are the photographs. And this is the graphical representation. Superior mesenteric artery. Intro video, this is aorta and superior mesenteric artery encasing the third part of the duodenum. Duodenojejunectomy was performed for the same. She did well after the surgery and her symptoms resolved and she started gaining weight. Superior mesenteric artery is a rare pathology with incidence that ranges between 0.13 to 0.3%, and the definite feature of this entity is upper GI obstruction, causing the compression of third part of the duodenum between superior mesenteric artery, which lies anteriorly, and the aorta posteriorly. This is due to the decreased angle. If the aorta and superior mesenteric artery angle is less than 25 degrees, then it causes the obstruction. Etiology, this is maybe congenital or acquired. Abnormally low insertion of superior mesenteric artery or high insertion of angle of treads dislocating the duodenum to a cranial position and causes the superior mesenteric artery syndrome. Acquired like corrective spinal surgery, spinal trauma, scoliosis, and after abdominal surgery like total proctocolectomy and ileal J pouch anastomosis due to tension and pulling down the small bowel mesentery. Severe weight loss, as in our patient, leading to the depletion of fatty cushion around the superior mesenteric artery is a major cause of superior mesenteric artery syndrome. Presentation, it may be acute presentation and chronic. Acute presentation like duodenal obstruction and chronic presentation like in our patient, long-standing vague abdominal symptom. Less common symptom of epigastric reflux, early satiety and gastric distension was present. Diagnosis, diagnosis is very challenging and often delayed due to the insidious presentation. High clinical suspicion is warranted. Barium radiography demonstrated the dilatation of first and second part of the duodenum with or without gastric dilatation. Contrast CT and MR angiography enables the visualization of vascular compression of duodenum and precise measurement of aorto-mesenteric angle and distance. Treatment option. Standard treatment option is duodenojejunectomy, another less invasive surgical strong procedure, but the failure rate is very high. Gastrojejunectomy may be previously performed, but post-operative complication rate is high, so avoided. Thank you. Yes, sir. But that was. Okay, sir. Okay, sir. Yes, sir.
Any other query, please?
Sir, in CT, they are not clearly mentioned the distance. This is an incidental finding post-operatively. Yes, sir. But मेरा presentation.
Sir, basically, I think this case was operated as a duodenal obstruction rather than a syndrome.
Yes,
When
sir.
during
This is an
operation they
incidental
found all
finding,
the
sir,
things and then retrogradely they.
We are. Yes, sir. Yes, sir.
Okay, thank you. Go for the next case, please.
Thank you, doctor. Now I would like to call upon. Thank you, doctor. Now I would like to call upon Dr. Udit Kumar from Miraz Lucknow Medical College. Will be presenting on a rare finding of cystic meconium peritonitis with ileal atresia. Over to you, doc.
Good afternoon, everyone. I'm Dr. Udit Kumar. I'm presenting a rare case finding of cystic meconium peritonitis with ileal atresia. Meconium peritonitis is an aseptic chemical peritonitis which results from the perforation. Sorry, sir. Which result from perforation of the gut in utero. Incidence is 1 in 35,000 live birth. Possibly causes incidence mesenteric ischemia, volvulus, intestinal atresia, meconium plugs, internal hernia, and Hirschsprung disease. Perforation of intestine in utero result in leaking of meconium into the peritonal cavity. Inflammatory reaction and the chemical peritonitis occur, which subsequently seals, forming intra-abdominal calcification. A newborn infant with no antenatal sonography reports presenting to a pediatric emergency with complaint of refusal of feed and inability to pass a stool. On examination, a palpable abdominal mass was found along with accompanying abdominal distension. Erect abdominal X-ray revealed a space-occupying lesion in the right hypochondrium and lumbar region containing air fluid level, pushing the dilated intestine medially. Upon USG, bowel dilatation was seen and a cystic mass with air fluid level was found in the right hypochondrium with acoustic shadow. Emergency laparoscopy was performed and distal ileal atresia with sealed proximal perforation and a meconium pseudocyst were found. Dissection of the involved small bowel, including the pseudocyst, followed by primary end-to-end anastomosis was performed. The post-operative course was uneventful. And discussion, the prevalence of intestinal atresia is 0.7 per 10,000 birth, and the prevalence rate of meconium peritonitis is 1 in 35,000 live birth. Surgery in neonate with cystic meconium peritonitis is expected to be difficult in view of underlying fiber adhesions, inflammations, and bleeding. We did experience difficulty in surgical dissection and isolation of intestine from the adherent cyst. Conclusion: delays in perinatal intensive care meant the neonate was operated under critical condition and emergency laparoscopy was performed under the elective. The skill of the surgeon prevent stage enterostomy in this case. These are references. Thank you, sir.
Dr. Udit, do you have that X-ray image?
Yes, sir.
Of that newborn X-ray image?
Sir, I don't have.
I think that is important. You should have inculcated in this particular presentation. X-ray is important in case of any neonate presenting with obstruction. That is important.
Yes.
Any questions from audience?
Thank you, sir.
Next, Dr. Sunita.
Thank you, Dr. Udit. The last presentation for the day is by Dr. Sunita Singh ma'am from AIMS Raebareli. Ma'am will be presenting on delayed presenting duodenal diaphragm with Hirschsprung's disease in a Down syndrome child, a case report.
Good afternoon all. Today I am discussing a rare case with abnormal age of presentation. Actually, this is a case of Down syndrome, which is clinically diagnosed by their characteristic craniofacial dysmorphic appearance, mental retardation, and the systemic anomalies, cardiac and gastrointestinal defects. Actually, in trisomies, there are various cardiac congenital anomalies associated with the cardiac effect is most common, and the GI defects including esophageal atresia, pyloric stenosis, duodenal stenosis, atresias, Hirschsprung disease, anal stenosis, and atresias are common. Contrary, if we see that 10% of Hirschsprung disease cases, 30% of duodenal atresia cases, and up to 30% of annual pancreas cases are associated with trisomy 21. Our case is a 10-year male-old child having facial features of Down syndrome, presented with complaints of persistent non-bilious vomiting after birth, after feeds associated with the abdominal pain, constipation, and failure to thrive since birth. Abdomen is distended. The plain X-ray shows a huge gastric air shadow with gas in the distal bowel. Echo was normal and DNA testing confirmed trisomy 21. Electrolytes were the normal, and upper GI contrast study shows a dilated stomach and a dilated first part of the duodenum with delayed retention of contrast in the 24 hours of film. CT scan shows with triple contrast that there is dilated stomach, first part of the duodenum, and abrupt tapering at the T1 level of vertebra. We also noticed dilated rectum. The CT scan shows a small, these shadows, these are actually berry seeds which we retrieved after during the surgery, and these berry seeds are causing the, we thought that these berry seeds are causing the obstruction at the small perforated diaphragm that we identify at the second part of the duodenum. We did the LATS procedure for malrotation, excision of duodenal diaphragm with transgastric, transanastomotic feeding jejunostomy and duodenoplasty over the excised diaphragm. Histopathology confirmed the duodenal mucosa on the excised diaphragm. Postoperative course was uneventful till 9th day of surgery. Patient discharged on oral small frequent feeds and supplementary jejunostomy feed, but postoperative constipation is persisting, and we do all the conservative measures, laxative, colonic wash, and enemas for 6 weeks, but symptoms are not relieved. Second admission happens 6 weeks after the discharge with complaints of features of intestinal obstruction. We manage the child on conservative lines, but he is failing. Then we did the upper GI contrast study, which shows the opacification of distal bowel, and there is no obstruction proximal or distally, because we saw that the stomach was dilated. Rectum was dilated, and patient has a Down syndrome and duodenal atresia. We suspected to rule out the Hirschsprung disease. So we did the lower GI contrast studies, in which the rectum is dilated. As such, no transition zone identified, but there is delayed retention of contrast in the rectum. Transrectal full thickness biopsy done 2 cm above dentate line, which show the absence of ganglion cell and the hypertrophic nerve fibers. Third surgery done approximately about 2 months after duodenoplasty. We did the descending loop colostomy and histopathology at the dissected along with the biopsy from the lower rectum just above the peritoneal reflection. Histopathology confirmed the ganglion at the descending colon. Post colostomy, child starts gaining weight and his symptoms were relieved. We did the definitive Duhamel pull through 4 months after the duodenoplasty, and in 2 years of follow-up, he has no complications related to Hirschsprung or the duodenal atresia. We know that the duodenal diaphragm can present delayed until adult life. This is, but the duodenal diaphragm with Hirschsprung disease is so rare that this is the 4th case report. For the explanation regarding the coexistence of both diseases, the etiology is different. Duodenal atresia is an anomaly due to the failure of recanalization of the duodenum, while the Hirschsprung disease is due to the aberration in the migration of neurontic cell. There is absence of ganglionic cell. So we search the literature, can there be a association between the both diseases? So we found that mouse model was created in which a sonic hedgehog gene mutation is created. The SHH and the Indian hedgehog, this IHH are the two genes we identified, in which SHH and IHH are associated with the annual pancreas. SHH associate isolation associated with the duodenal stenosis, and IHH is associated with the colonic ganglionosis. Unfortunately, we can't do this study as the this molecular diagnosis lab is not there in our institute. So to conclude, concurrent Hirschsprung disease and duodenal obstruction in this case is a important differential diagnosis, which can be considered in cases of trisomy 21. Hedgehog genes can play an important role in mammalian gut patterning, and infants with multiple concurrent GI malformation, it can be an area of future research. Thank you.
Thank you, ma'am, Dr. Sunita. I would like to ask you one question. Does these genetic anomalies which you have discussed, the tests are available in our country?
These are?
Genetic aberrations are, you have discussed genetic aberrations. Does these tests are available in our country?
So Apex Institute, especially, I don't know, but if AIMS has a facility, otherwise the ICMR labs, Hyderabad have these few labs, only this have facility all over the India. Thyroid functions are as a routine protocol we used to do. I don't mention here. In all cases of Hirschsprung, yes, it was the normal. Sir.
Answer to your question, because I have been doing fair amount of genetic studies in my patients, because that has excited my interest. So there are some labs called MedGenome or some other. There is 1, 2, 3 in Delhi. There are some in Hyderabad. Okay, they do extensive. It's called next gene sequencing, where the entire genome, human genome, is assessed and abnormalities are picked up. And if you have a focal problem at hand and you want to assess syndromic, then you can do limited gene sequencing. Both these are available. They are at a sizable cost, but they are available in India.
Thank you, sir. Thank you, sir.
Presenting and all delegates for patient cheering, and thank you the organizing team for giving opportunity as a chairperson. Thank you. Thank you.
Thank you, sirs. I now request all the chairpersons to kindly come over to the dais for a group photo session. This will be followed by a valedictory function. So the prize winners for the oral sessions will be announced shortly. Rohit. Kindly bear with us for 5 minutes. The results are being calculated. and we'll head towards the validatory function later on.
सर आप ही को प्राइज देना, मैं आप ही को बुलाने वाला हूँ स्टेज पे. So I will quickly just begin the valedictory function. I will invite Professor Bhatnagar to come on stage and give the first and second prize for the free paper to the residents and encourage them. Please, sir, welcome. Next, first long oral wala, it's all right. So, in the long oral paper, the first prize goes to Dr. Rahul Dev Sharma for his paper Balloon Venoplasty as Primary Modality for Treatment of Budd-Chiari. Dr. Rahul, please. Second prize in the long oral paper goes to Dr. Anju Verma for a paper on Peutz-Jeghers syndrome. Short orals have we finalized, Pratyu? You are writing the certificates, so we'll just wait for 2 minutes. Yes, please. Okay. So the first prize in the short oral paper goes to Dr. Anjali Jalan for a paper on Litter's hernia, a case report. The second prize goes to Dr. Shalvika Kashyap for a paper on rectal duplication presenting as perianal mass. Yeah, please everybody come on the dais for a group photograph. Thank you very much for staying back so late. I'm really happy that. Please come on stage. Everybody please come on stage. Please our staff also please come on stage. Yeah. Yeah. So please. Come.
This background.
Thank you, sir.
So just quickly, I would like to offer the vote of thanks. And first and foremost, all the senior faculty, Professor Bhatnagar, Dr. Sandeep, Dr. Rectal, who stayed throughout, Dr. Rawat is here, all the senior faculties who stayed throughout the entire 2 days and made the academic discussions a great success. Thank you very much, sir. Thank you for staying the entire 2 days. Thank you to all the delegates who have come from all over India. And I really thank all our staff, the AV team, telemedicine team. Special thanks to Dr. Pratibha, Dr. Anju, and Dr. Poojna. They have worked extremely hard, and the entire hall management was done by them. A big clap for them, for our staff. I will also like to thank all the sponsors and the print media and the organizing team. And if anybody wants to say anything, any feedback, quickly.
I think the program which they have organized, they are very good in terms of everything, hospitality, CME, the delegates, everybody enjoys. So big hand to the organizing team. Thank you.
I would like to say 4 words. I am coming from Mumbai, flying over Mumbai to Lucknow. And I will thank SGBI time for their great hospitality and great show. They have managed such a wonderful, yummy food, and these presentations were wonderful. Academic discussion was very high class, and I thank you, the Ankur sir, Basant Kumar sir, and the whole team of SGBI for their relentless efforts for making this show such a great success. Thanks, SGBI team, thanks. Love you all. लखनऊ की तहजीब से बहुत ही अजीब है, इसका प्यार बनता रहेगा और लोग प्यार में ऐसे ही आते रहेंगे।